6.
Thank you, Bhagya.
Thank you. So, respected President Foxy, Dr. Jaideep Tang, Secretary General Dr. Madhuri Patel, ICOG Chair Dr. Parul Kotadawala, ICOG Secretary Dr. Sarita Bhalerao, the conveners, the series conveners, Dr. Sheila Mane, Dr. Parag Biniwale, and Dr. Charmila Ayabu, and the convener for Adolescent Certificate Course, Dr. Sampat Kumari, Madam. A warm welcome to all of you for this 3-day ongoing course. Yesterday, we had a session full of academics, really wonderful new things for everybody to learn. And today we continue the trend. तो एडोलेसेंट एज के ऊपर शायरी कह के मैं आगे पढ़ना चाहूंगी कि रात भी नींद भी कहानी भी हाय क्या चीज है जवानी भी. You know, all of us think of fondly of our young age. शरबते रंगीन लगता है सादा पानी भी. When you are young, even if you drink water, it tastes like शरबत. So शरबते रंगीन लगता है सादा पानी भी, हाय क्या चीज है जवानी भी. And it is such a blessing to be associated with Adolescent Health Committee because we all keep feeling that we are still young, still those, Jawani ke din, we are still living them. So warm welcome again to all of you. It's an extreme pleasure that our Secretary General of Foxy, Dr. Madhuri Patel, is here amongst us. And I would like to give a formal introduction to Madam and then invite her for her blessings. Of course, Madam is somebody that nobody needs to be told about in Foxy. Dr. Madhuri Patel, naam kafi hai. Lekin fir bhi, I will do the honors. I will just go ahead with the formal introduction. Madam is Secretary General Foxy, Editor-in-Chief, The Jogi, which is our flagship journal, Joint Secretary Foxy in 2009, Committee Member of FIGO Preterm Birth, Honorary Clinical Associate at the Nauroji.
Thank you, Supriya. Thank you, Supriya.
I know, Madam, otherwise the entire session will be consumed with your CV. So I think without much ado, I will invite you for your blessings. Thank you so much, Madam. We know you are extremely busy with the election process. Still, you have joined us very indebted. Please give us your pearls of wisdom.
So thank you, Dr. Supriya, for your kind and warm words. Respected our Chief Guest, Dr. Jaideep Tang, Dr. Parul Kotrawala, ICOG Chair, Dr. Sheila Mane, Vice Chair of the ICOG, Dr. Sarita Bhalerao, Secretary ICOG, Dr. Parag Binewala, Series Convener with Dr. Shamila, Dr. Sampat Kumari, my dear friend, and all of you are my dear friends, okay? And convener of this program, coordinator Dr. Supriya Arwari, Supriya Jaiswal, and Dr. Radhika Gauri. And of course, today is the second day. Yesterday I was there, but because of some commitment, I had to leave the webinar. And I learned that there were more than 300 delegates, they joined for this certificate course. So this is very, very achievable thing. And everybody aware that adolescence is the age. It neither comes in the child or it nor comes in the adult, So what happens, and they have not much health problem. That's what our community understands. And that's why they are neglected every time. So now we are here because Dr. Sampat Kumari, Dr. Jayam Kanan, and so many people started this, move for the adolescent health, and all our committee, chairs, that we know that adolescents are very, very important for our community because they are the future generation. And at present, we are 253 millions we have in as an adolescent. That means the 1/5 population of the India. And if we don't take care of them, because they have a health problem like others, but they are not so much more, or they are ignored, even the parents sometimes ignore, teachers ignore. Suppose they have some problem, suppose she says, I have backache, then we say, oh, it must be just like that. How can you get in a young age? Suppose she has a headache, we just ignore. But they have a menstrual problem, they have a very much, they are very much, emotional, and we don't take care of them, they can land up with many, many problems. So we know that 5, things which, we should be taking care is the mental and emotional well-being. NCDs, injuries and violence, including gender-based violence, nutrition, and substance misuse. So these are the 5 things we have to take care of this adolescent. And for that, our government has also started the Rashtriya Kishore Swasthya Karyakram, and they are including these 243 adolescent group. And for that, so we all are aware as an obstetrician and gynecologist, as a government, and as an organization, and our college is doing fantastic work for this adolescent health. And so today's speakers are, if I say second day, Dr. Apurva, Dr. Girjava, Dr. Rajal, Dr. Supriya, Dr. Reena, Dr. Asha, Dr. Lakshmi, Dr. Sarita, and chairperson, they are the eminent, speakers and chairperson, and do the justice to the topics, and we'll learn many things which will help us in practice in day-to-day practice to implement to our adolescent women for the best health. And I really congratulate Dr. Parul, Sarita, Sheila, Sampat Kumari, and all of you, Sharmila, for the Supriya, of course, for the Parag, for the best apt webinar. And I wish you all the best. Thank you once again for giving me the opportunity.
Thank you, ma'am.
Thank you. Thank you so much, madam. And madam, it's an honor to inform you that as of now, 610 delegates have registered for this course. And I'm sure slowly all of them will join us in this webinar. So it's a real feat. And I think 100 out of 100 points go to Sampat Kumari madam, who is a champion of, adolescent health, and ably guided by Parag, by Sheila ma'am, by Charmila ma'am, to put this program together. And with such good office bearers at the helm of affairs like Madhuri ma'am and Jaideep, I think we'll do great work, not only this year, but years to come. Next, I would like
I want to comment. I want to comment one thing.
Yes, ma'am.
Yeah, I want to comment that if Supriya keeps on saying Shairis, I think we'll forget all the, our OBGY and we'll be into the Shairi only. Yeah. Supriya, your Shairis are so good that people come to listen to your Shairis.
Thank you, ma'am. Ma'am, just so you know, whenever I go comparing, people tell me, "Aap abhi profession hi badal do. Don't go back to obstetrics."
Yeah, you're motivating others also for that. Good.
Thank you so much, ma'am, for those sweet words. Next, I would like to call our guest of honor for today. That is none other than Dr. Sheila Mane, madam. I'll quickly introduce her. Again, one more personality who requires no introduction for the people of Foxy. But just to complete the formality, Dr. Sheila Mane is currently DNB faculty at KCG Hospital, Bengaluru, ICOG Governing Council member, and presently ICOG Vice Chairperson. President Isopub Society, Bengaluru, President Bengaluru Menopause Society. I think, madam, it will be easier if we make
Thank you, Supriya.
You're not the president.
Yes.
And a very sweet personality, very lovable personality of Foxy. And madam, requesting you to please give your words of wisdom. I'll quickly just stop my slide share. Yes, ma'am.
Yeah. Thank you, Supriya. Nice to hear your shairi as well as the kind words from you. And I thank Dr. Parul Kotadwala for giving me this opportunity, as well as Dr. Jaideep Tank and Madhuri for encouraging us to do this certification course through ICOG. And adolescent today, I think Dr. Madhuri has already told all of us about what population we have. And I think we have the second largest population of adolescents in the world. And I think all of us have to really count on that, because our future generation depends on that. And today's topic, particularly STD, IC, and POXO, all those topics which are discussed, they are very important. I know Apurva is here. Sex education is still taken very easily in schools, but now there is a need where Foxy should come forward and do something, because unless and until we do that, I think they try to learn from the peer. I must share with you that it happened to me that we had a reproductive health conference, and we met Dr. Naveen who works for CASP. And the scenario he was telling among youngsters about STD, IST, which is really frightening. So it's very important that we educate them in a proper way. had a word with Dr. Durusha, and Dr. Durusha told me that she has come out with an app that is too shy to ask. All the young people and adolescents can download it and learn. It is in 5 languages. All their queries will be answered. So that the adolescents can log into this app and they from that, because everybody has a smartphone now. So let us see to it at least the correct information, because that is our prime responsibility. So whosoever delegates have joined today, I'm very happy to see 600. You think about it, that you are going to spread this message about the adolescent health and all the aspects to as many adolescents, because I must tell you that most of the adolescent chairpersons are part of this, like Dr. Parag, who was there, then Dr. Sampath Kumari She is going to talk, okay, and all of them, Dr. Jayam Kannan, okay, all of them have worked. So it's very important to talk to them. So you have to reach out to them. They are not going to. So we should go to schools, we go to colleges, and we are still continuing to do that, because we have to catch them young. That is our responsibility. So let us move forward, that adolescent health becomes a priority for us, not only in our clinics, but also for the society. And think about it, that how to go. And the Dr. Supriya, who is currently the adolescent chairperson, and I must say the another Supriya, all will guide you, will help you. Any queries, you can come to all of us anytime. And don't forget, have that app that is too shy to ask. And I wish all the best for this program, and looking for listen to excellent talks from all of you, and best wishes to all the faculty and Dr. Sampath Kumari and Supriya Square as well as Radhika. Thank you.
Thank you so much,
Thank
ma'am.
you.
That was really very, very, the perspective was wonderful. And definitely all of us should utilize what you are talking about, this app. So moving forward, now I would like to also invite and welcome the other dignitaries that are present there. Dr. Parag Biniwale, a very dear friend, always there, to guide, to give us advice, and who is also the series convener for today. Welcome, Dr. Parag. Dr. Charmila Ayavu, she was present yesterday as the series convener. Today also, I welcome her. Dr. Sarita Bhalera, who is the Secretary ICOG Chair. She will be joining us soon. We will now be giving out the pre-test, and also before that, Sampath Madam, who is the convener of this entire course, will address us. Sampath Madam is the Professor, President, Board of Studies, OBGYN, TN, Dr.
Supriya, leave it, Supriya. Yesterday,
I think yes, ma'am. It will be like showing a candle to the sun. So I think I will just move forward. I'll hand over to you to give a brief overview of yesterday's course, and also what are we expecting today. Over to you, ma'am.
Thank you, Supriya. First of all, I should thank our President Jaideep Tank and the Secretary General Madhuri Patel Madam, and the ICOG Chair, Dr. Parul, and Secretary Dr. Sarita, and Dr. Parag, who is an incoming chair, for allowing us to do this program. And yesterday we have, I think as Supriya told, we have 620 registration. So for the delegates, I'm telling all the 3 days you have to attend, and all the 3 days you have to participate in the test. If the post-test, if it is more than 50 only, certificates will be given. So the pre-test will be put in the chat box. You have to just click the link. Yesterday, we had the topics of lifestyle, nutrition and exercise by Dr. Parag, and adolescent obesity by Supriya Arvari, and school health program, Supriya Jaiswal, sorry. So a school health program by me, and the teenage origin of adult disease, that is in the sports, what are all the problems, sports adolescent girls by Dr. Sarita, and the adolescent PCOS by Dr. Swarna, and adolescent endometriosis by Dr. Pradeep, and AUB in adolescents by our Dr. Jayam Kannan, and finally Dr. Adolescent Endocrinology by the endocrinologist Dr. Usha Sriram. We had a wonderful talk yesterday, and today we will start with the scientific session, the first session being by Dr. Apurva Kumar Datta. Before that, we will go with the pre-test. Neelima, you can post the pre-test. The pre-test 20 questions will be there. 10 minutes will be given. You have to answer within 10 minutes. Dr. Parag, do you want to tell anything? He's not there.
No, I'm here, but then no, let's not waste our time.
Okay, sir.
Let's start with the pre-test.
Okay. So the link is available. All of you start. 20 questions, 10 minutes. Link is there in the chat box. Dr. Kavita. Those who have joined late, pre-test link is in the chat box. 20 questions, 10 minutes, 2 minutes over. Those who have joined late, the pre-test link is in the chat box. 20 questions, 10 minutes. Please do it. 5 more minutes more. Yes. Nilima, put the links once. Those who are joined late, the pre-test link will be in the chat box. 20 questions, 10 minutes, 2 more minutes are there. Kindly fill it. Hello.
Last 2 minutes remaining. All delegates, please make sure you fill the questionnaire pre-test and post it.
Somebody has commented tougher than yesterday. Adolescents are becoming tougher day by day. One more minute. All of you, please click the pre-test link in the chat box and do it. 20 questions, 10 minutes, 9 minutes over. Yes, done.
So, madam,
Questions are, 1 minute, Supriya. Questions are not of super specialty. See, the questions are given by the speakers. You listen to the speakers. The answer will be in the talk. Now I hand over the mic to Dr. Supriya. Supriya.
thank you so much, ma'am. And there is no worry about the questionnaire being tough, because it is exactly the purpose why we are all here together, is to solve those questions for you. And academic section that follows is going to answer each and every query of yours. So without much ado, I would like to invite the chairpersons for the next session. I will just share my PPT and invite all our esteemed chairpersons for this first session of the day 2. And on behalf of my co-conveners, that is Dr. Supriya Jaiswal and Dr. Radhika Gauri, I invite all of you to enjoy this academic session. Dr. Supriya Jaiswal sends her apologies because she is busy with organizing Adolescent Health Conference. So I'm standing in for her. So on behalf of all 3 coordinators, a warm welcome and thank you to Sampath ma'am for giving us the opportunity. Since the pre-test is done, I invite the chairpersons for the session, for the first session. First session chairperson is Dr. Fessy Lewis.
Oh, Supriya, Fessy is not there.
Yeah,
Fessy
he has a medical emergency in the family, so sir could not join. We'll definitely miss his presence. It's an honor to invite Dr. Ranjana Khanda, the National Vice President of Foxy 2017, ICOG Governing Council member, Executive Member, National ISOPAP 23-25, and past President of Allahabad OBGYN Society. A warm welcome to you, madam, for joining us for this session. Next chairperson is Dr. Vidya Tobi, madam, chairperson, Food and Drug and Medical Surgical Equipment Committee, Foxy 2018-20. Best Committee, Foxy Award, Dr. Merudara Ansotia 2020, now currently ICOG Governing Council member. Madam, a warm welcome to you. And I would request both our chairpersons to please invite the first speaker for the day, that is Dr. Apurva Kumar Datta. Ranjana, madam, may I request you to please introduce Dr. Apurva?
Sure. It's a real pleasure to call upon Dr. Apurva Kumar Datta for his talk. And as we all know that he's chairperson of the Sexual Health and STI Committee of Foxy, National Coordinator, Sexual Medicine Committee of Foxy, National Coordinator for Foxy's CME Workshop for Safe Abortion and Contraceptive Cafe 2020. And he's the winner of several awards and faculty in many national and international conferences and published many papers. Currently, he is Medical Director, Sri Durga Clinic and Fertility Center, Dhanbad, Jharkhand. So welcome, Dr. Apurva, for your talk.
Thank you so much, Ranjana ma'am, for really warm welcome. And at the outset, I would like to thank first the Foxy, our President, Dr. Jaideep Tang sir, our Secretary General Madhuri madam, all the Vice President, ICOG Chair, and definitely the person behind all this program, Sampath Kumari madam. Ma'am is like a mother figure, a friend, a guide, and what not, ma'am. Thank you so much, ma'am. And with the two great, senior Vidya ma'am and Rajana ma'am as a chairpersons. Now, when we are talking about the sexuality itself is a, very much, hidden topic. People don't want to talk about it. And that too, the sexuality in adolescent is really a tough one. Now, many times, being a chairperson of the Sexual Health Committee, when I am going to approach to a lot of, high schools or colleges for giving the sexuality education, comprehensive sexuality education, we are getting a lot of opposition from them also. So it is very, we have to understand what is the importance of sexuality and adolescence and why this topic is so relevant that we should know about it. My dear friend, when we are talking about the adolescent, it is a term derived from the Latin word adolescence. That means to grow, to mature, and it is a transition from the childhood to the adulthood. It is the progression from appearance of the secondary sexual character to the sexual and reproductive maturity. That is what about the adolescent. When we're talking about the categorization, now adolescent is a period between 10 years to the 19 years. And we divide it into the three. That is the early adolescent between 10 to 13 years. Then there is a spurt of the growth of the development of the secondary sexual character. The middle adolescent between the 14 to 16 year. Here, there, the children, the adolescent are want a separate identity from the parents. It is new relation to the peer group, attraction to the opposite sex, and a lot of experimentation they want. And the late adolescent, that is between the 17 and 19 year, it is a distinct identity, well-formed opinion and ideas. That is about the categorization. When we are talking about the statistics, now India have at least 22% of adolescents, and it is the highest number of the world. So when we have that much of population, that means we have that much of problems too. So it is my sincere effort with this topic. I just want to have that to how to deal with the problem when it is come into the sex and sexuality in the adolescent. Now, coming to Indian statistics, the early marriage. Now, less than 26% of the girl having less than 15 year, and 54% of the boys less than 18 year are getting married, which is the highest in the world. And 20 to 30% of adolescent boys are sexually active. 10% of adolescent girls are sexually active. Approximately 60% adolescents know about the condom and contraceptive. There is approximately 5% having gone into the drug abuse, and 50% of all the HIV new infected in a age group is between the 10 to 25 years. And the adolescent abortion is again a very alarming. So this is the importance that why the sex and sexuality is very important in case of adolescent. Now, what are the growth and changes? Now, sexual, it is the increase in the sexual organ. There's a enlargement, there's a maturation. The boys can find the erections or the sperm production and ejaculation. There's a menarche, ovulation in the girl. There is an increased sexual awareness, the desire, change in the attitude and the sexual behavior, initiation of the sexual activity, curiosities, and have a experiment. And same, they also want to have a sexual experiment. And there's a change in the way the adolescent related to the adult and to each other. That is the sexual orientation. These are the growth and changes which a adolescent feel about the sex and sexuality. Now, what are the factors influencing the sexual behavior? The personal factor, the education, the social class, the knowledge and availability of the contraceptive, the family background. For example, if the family is very orthodox, and even I am experienced when I was a kid, and when there is some ad of like HIV AIDS or something, some ad like the condoms, you in our family we are usually change our the channel. So this is what in the families does they have. So this again have a very influential factor about the sexual behavior. The parents value attitude and control and stability of the paternal marriages and domestic violence. Again, it has a very negative impact for the adolescent. Now, the social factor, the peer pressure, because the youngsters, they want always the experimenting and everything. When there is a peer pressure, they are actually doing a lot of things which should not be done. So peer pressure has a very major effect. The mass media, absolutely. We nowadays we are surrounded with the mass media, the social media, and it is the both the way. It also has a good effect as well as the bad effect. The religion teaching, the culture and the tradition, and definitely the sex education. It was seen where the sex education is given, the sex and sexuality and the development is much more better than the from the society where it is not given. So I have already stated the technology. It is actually double-edged sword. It has both, and as like the youth also has a double-edged sword. So the internet afford adolescent free. You know what happened when the adolescent have a lot of queries. They are search into the Googles, and it contain a lot of unfiltered information. They are asking to their their peers, to their friends, and they are equally knowledgeable. So this is again very important, and they are getting a lot of misnomers, misconception about the sex and sexuality. Now, what is the role of the parent? The parents can seize the moment. They should be directed. Consider your teen's point of view. Don't argue. If they have certain point of view, we also give respect and try to, if it is not wrong, we have to try to change it very politely. Move beyond the facts, initiate more discussion, and use the correct name for the body part. This is again very, very important. Now, the schools have a lot of, roles, the teachers, the healthcare worker, the school health counseling, they can teach about the safe touch and the unsafe touch. This is again very, very important. Now, again, the school can say that you can say no if you doesn't want. And you should, have to say it very politely, give the reason why I am not, say why I'm saying no, repeated refusal, walk away, ignore the person, avoid the situation, find other support, and talk about your own feelings. So it is again very, very important. Now, what is the consequences of sex and sexuality in adolescent? There may be the early pregnancy and parenthood. Now, this is again itself has a lot of consequences. And our next speaker, I will talk on the teenage pregnancy. There is a high mortality, mobility, a lot of problems to the baby as well as the mother. There may be unsafe and criminal abortion. There may be low birth weight babies and increased infant morbidities. There is a STDs. There is an increased chance of the violence, including the sexual violence. There's an economic impact and hindrance in the career growth. Now, what is the adolescent pregnancy? Again, it's a very important. About 16 millions of the girl in India age 15 to 19 year gave birth annually, and it is really had a very negative effect on the female health, overall health. And I'm not going to detail, but the consequences, it's increase associated with the anemia, the IUGR, the hypertension. There is an increased maternal mortality and morbidity, eclampsia, pulmonary infection, hemorrhage, and what not. About the abortions, yes, a lot of adolescents, due to lack of the knowledge, lack of the sexuality education, lack of the safe contraceptive in the adolescent, they are going to the unwanted and unsafe pregnancies. And it's lead to a lot of abortions, leading to a lot of morbidity and mortality in case of adolescent. So next is the sexual violence. Again, any sexual activity between an adult and child below the age of the 19 or non sorry, below the age of the consent, that is the 18, or non-consensual activity between the minors include fondling of the genitalia, masturbation, oral sex, vaginal or anal penetration by a penis or finger or other objects. This all come into the sexual abuse. And unfortunately, in India, again, we are the capital of the sexual abuse in sexual abuse in case of the child. So the consequences is has a physical adverse physical health as well as adverse mental health. Now, coming to the STDs. Again, I am doing the sexual medicine practice, and last month I have seen at least 10 cases of gonorrhea. What we are thinking that during our UG time, we are seeing a lot of cases, but it was thought that in mid somewhat this gonorrhea and everything, syphilis has gone. But what I am feeling that again there is a research. So it is very important to know about the STDs and to treat our adolescent and teach them about the STDs so that they should avoid the permanent disability due to the STDs. Now, what are the various barriers? There's a social barrier and the economic barrier, the law and the policy, the health system and the healthcare workers. Now, because we are many times we are judgmental. When a young patients are coming with some advice regarding their sexuality, we are really judgmental about them, and this is really give a lot of negative impact. So we should have a clinic like adolescent friendly clinic so that they can discuss and we can give the good advice to them. Now, why there is not cause for seeking of the treatment? Because the confidentiality issue, the lack of privacy, non-availability of the special center for that, there is a poverty, there's a long queues, the reluctant to approach the male provider, judgmental attitude of the staff, own perception of the cause of the disease, inability to understand the magnitude of the problem, the social stigma and status at the household. So this actually make the life of an adolescent more miserable. A sexually healthy adolescent can it's their right to get a actually the correct treatment, correct knowledge of all those things. Now what we can do, now we can provide the information like the sexuality education, clear their myths and misconception, promote the concept of the marriage and abstinence before the marriage, provide premarital counseling, promote safety issue for the reproductive and the sexual health as preventing pregnancy and STDs, make the health service accessible to them and deal with the consequences of unsafe sex. Now, who can do that? The teachers, we not only the doctors, but the teachers, the doctors, the nurses, the peer educator, and the community worker. They can all can help them to overcome with their myths. Now, what is the role of the healthcare worker? We should ask them: have anyone ever touched you in the way you don't want to be touched, or has anyone forced you to do something what you don't want to do sexually? Is there anything else that you could like to share, or there is any other topics you would like to discuss? Now, these all topics are very personal to them, and many times on the first visit they are unable to speak about that. So we have to give them time so that they can speak, and actually we can understand their actual problem and treat them accordingly. So what is the social, in the social way, lots of, menstrual hygiene. We have to ask them about menstrual hygiene management. There is stress factor. We many times now the NEET exam is there, and before that the class 12th, board results were there. We are often seeing that in Kota, the students are committed suicide. So there's a lot of pressure. And as a provider, as a adolescent friendly clinic, we should advise them on how to deal with this type of stress and how to avoid this drug abuse and etc. We should also ask them about good nutrition. And because those who have a good nutrition and hemoglobin of 12 gram, tomorrow they will be the mother. So this is the vicious cycle. If today in adolescent we have a good nutrition, we have a good hemoglobin, then definitely they will be good mother, so their baby will be good. So this is again very important to deal these things in case of adolescent. The exercise, we should avoid, ask them not to have the overweight and avoid the junk foods, and definitely vaccination to prevent the STDs. The rubella vaccination, MMR vaccination was markedly advocated by the government of India, and it is freely available elsewhere, including in my state, Jharkhand. I was the coordinator of that, and HPV vaccine for the cervical cancer prevention. Now about the POSCO Act, I'm not going to tell because the another speaker will deal about it. It is the protection of the child from the sexual abuse. It is established to protect the children against offense like the sexual abuse, sexual harassment, and pornography. So there is a lot of data, and they have concluded the findings highlighted the need of the sexuality health education through cooperation with the school for offering appropriate education to the student parents and school staff. No, this will definitely increase their knowledge about the sexuality, and those we can able to avoid the teenage pregnancy, STD, unwanted pregnancy, unsafe abortion, and etc. So the take-home message, the guided by the questions from the hardness mnemonic, that is home, education, activities, drugs, sexual activity, safety, and suicide. The CDC's 5P approach to obtain a sexual health history. The 5 Ps includes partners, sexual practice, past history, pregnancy, and protection. So that's all from my side. Thank you for the kind listening. And at the outset, I really want to thank uh, uh, Sampath madam, because again, ma'am is helping me for preparing this slide. So thank you so much, ma'am, and giving me the opportunity. Over to the chairperson.
Thank you so much, Dr. Purva. It was a very good talk, complete in itself. And one thing which is very important is that it's always the mothers who play the most important role. They should understand their daughters And at the time of adolescence, when the child is stepping into that age, then it is very mandatory that the mothers should guide the daughters and the fathers should guide the sons. That is what makes the best out of them, out of the adolescence. The mother should always tell the child about good touch and bad touch. And she must caution the child, but also tell her that she's a best friend. And whenever there's anything she would like to share, then the mother is there for her. And I think that is the best way, because if you have a healthy relation with your daughter, then it goes a long way in betterment of the child.
Absolutely.
Thank you so
Absolutely,
much,
ma'am.
ma'am.
Thank you.
Yes.
Thank you.
Thank you, Apurva. A request to all the speakers, after you're done with your talk, please do check the chat box. If there are any queries, you're requested to sort them in the chat box, because we have such an action-packed academic session. We don't have actual time for audience interaction as of now. So please do check the chat box. And moving forward, I would now like to request the next chairperson for the day, Dr. Vidya Tobi madam, to please introduce the next speaker, Dr. Adhika Gauri. Dr. Nirja Batla, unfortunately, will not be,
Dr. Girja Vog.
yeah, she will not be attending. So, Dr. Radhika, I think I will request you to share your slides and share your CV so that the chairpersons can introduce you and we can proceed with your talk.
Radhika?
Gauri, make her co-host, please.
A very good evening to one and all. At the outset, I thank Dr. Parul Kottadawala and Dr. Sarita Bhalerao, and mainly my dear friend Dr. Sampath Kumari, who is always there. And whenever I talk on any adolescent topic, I remember her for her school programs. So many she did. So today, Dr. Radhika Gauri, she is talking on pelvic inflammatory disease. I think it is very important to know about this, because as Dr. Apurva was talking about the very unknown topic to all, because most of us, we don't talk about the sexual abuse and all, and the consequence of these things, and the improper menstrual hygiene also leads to pelvic inflammatory disease. So this talk will be given by Dr. Radhika Gauri, and she hails from Tirunelveli. So I just wanted to her CV slide, if she can put it.
Vidya Topi, she is the consultant in ESI Hospital, Tirunelveli.
Okay. I know her, but I wanted to introduce to the
No problem.
audience.
Then proceed.
Yeah. So over to Dr. Radhika, please.
Thank you, ma'am. Thank you for the kind words. Thank you, Sampath ma'am, and thank you, Parul sir, for giving me this opportunity. And I'll start the presentation. So today our talk is on pelvic inflammatory disease, and especially in the adolescents. And as we all know, it is inflammation of the female upper genital tract, and it is polymicrobial in nature. The core organisms, as our previous speakers said, it's Neisseria gonorrhea or chlamydia. As we used to think, in India, we all think the adolescent children do not have sexual activity, but actually, to be honest, I think more than 50% start their initial sexual activity even before 16 years. And other organisms are Gardnerella vaginalis, Haemophilus influenzae, and Mycoplasma genitalium, and so many other organisms. So the disease burden itself is very important. Worldwide, WHO data says it's 448 million new cases of curable STIs diagnosed annually. And these are curable, and we should prevent the sequelae of the STIs. And STIs are the major chunk of our patients, actually. The women with the STIs are the major chunk. The greatest risk is in adolescent girls, because the recurrence rate is high,
And since they are quite young, they tend to have repeated sexual intercourse, and they get married again. They are susceptible to recurrent infections, and that is the main reason for concentrating on the adolescent girls and preventing at that stage. And here I would wish to say even the other diseases like the lifestyle disease, obesity, and everything should be concentrated during the adolescent. And STIs play a major role in PID, but PID cannot be equated to STI. PID results in can be a result of many other infections also, like tuberculosis and etc. And but the major cause is sexually transmitted infection. So 125,000 to 150,000 hospital admissions a year, and it is very costly, expensive for the patient and for the hospitals and the countries. So why it is common in adolescents? The main reason is the increased mucosal permeability, and there is a larger zone of cervical ectropion in the adolescents, and the lower prevalence of protective anti-chlamydial antibodies, and increased risk-taking behavior, especially because of ignorance of these complications. So the FOXI guidelines, actually clearly there is a guideline where it clearly indicates the different causes of pelvic inflammatory disease, but it is in general, so it can be used for adolescents also. The primary causes are our chlamydia trachomatis and Neisseria gonorrhoeae. Secondary causes are, when they have inflammatory bowel disease, genitourinary infections, atypical infections like tuberculosis, and due to secondary to intrauterine device insertions. So the contraceptives and PID risk, that is a controversial issue here. The use of intrauterine contraceptive device increases 2 to 9-fold risk, especially Fusobacterium and Streptococcus actinomyces, but only during the first 20 days of insertion. So if we give a prophylaxis at the time of insertion and advise them to either abstain from sex or cover it with barrier contraception, then we can prevent the PIDs. And we should also use strict aseptic precautions during the insertion. The IUCD user with symptoms can be treated with antibiotics, and we have to follow them up after the next periods. So if symptoms are not resolved, only then the IUCD should be removed. If any patient with IUCD, if they come to us, we have to first treat them with antibiotics, and if not resolved, then we have to go to the next step of removing the IUCD. And after treating, once the infection is completely resolved, then we can again give the insert the IUCD. So then now the COC pills and the controversy. Here some data says the thickened mucus, the cervical mucus decreases the, it acts as a protective barrier, and also the decreased menstrual flow and the modified local immune response from the COC pills give a protection. But they can increase the zone of ectopy also, and that again increases the susceptibility. So OCP, some studies suggest no effect on OC pills, but it is always ideal to give the OC pills to women, girls, especially adolescent girls who are sexually active, if they fit into the criteria. So what is the primary prevention? Because in this case, there are short-term sequelae, long-term sequelae. So we have to prevent them at the, do a primary prevention. So the primary prevention is the delay the onset of sexual activity. So it's best to start sexual activity after 16 years. That gives them some immunity and antibodies, and so it will help them to prevent the thing. Second is the strict use of barrier contraception and reducing the number of sexual partners, avoiding unsafe sexual practices, abstain from sexual activity until symptoms fully abated both in patients and the partner. And once they have completed the entire treatment regimen, it's better to start the sexual activity after that. So again, in the US, it is recommended to screen for chlamydia for all sexually active women. Anyway, it is not feasible in India. So why adolescent girls are vulnerable? Because they often have tests with they test themselves for their they have the risk taking behavior, so their sexually transmitted diseases are common, and as I said earlier, increased mucosal permeability, and the young adulthood, multiple sexual partners, immature immune system, tuberculosis, and poor menstrual hygiene is also an important factor. So what are the effects? Acute effects are endometritis, acute salpingitis, oophorytis, tubo-ovarian abscess, pelvic peritonitis, and perihepatitis. So it also causes Fitz-Hughes syndrome. That's mainly by chlamydia. And the long-term sequelae are chronic pelvic pain. The rate is 25%. It usually occurs, the pelvic pain occurs with the menstrual changes. And also it can be due to adhesions and hydrosalpinx. And there is impaired fertility. 50% of patients have silent PID due to chlamydia trachomatis. And ectopic pregnancy, 15 to 50% due to direct damage to the fallopian tubes. These are the long-term sequelae, and they are quite dangerous, and it affects the long-term health of the woman. So what are the diagnostic considerations? Clinical acute PID is a little difficult to diagnose because it's like a general presentation, especially in adolescents, because most of the time we do not get the clear history from the adolescents. The adolescent children are often accompanied by their mother or parents, and they do not want to disclose their high-risk behavior. And so there are few, we have to practice certain ways to get the history from them. And so there are symptoms are sometimes subtle or even asymptomatic. Non-specific symptoms are also, they present with non-specific symptoms like increased white discharge. And usually we see in the OPD, commonly the women bring them with white discharge. So we should elicit a detailed history. When the patient is alone with confidentiality, we have to talk to the young girls and slowly get the history if there is any possibility of sexual interaction. And some of them present with lower abdominal pain, with the dysuria. This is another common presentation. There is vaginal discharge, dysuria, urethral pruritus, and mucoid, mucopurulent or purulent discharge, and irregular periods. And delay in diagnosis leads to disasters and long-term sequelae. So early treatment is better. So the diagnosis is tricky in adolescents because normally in South India, we don't do straight away, we don't do a speculum examination, especially in sexually, in young girls. So it is a bit tricky, unlike in the older women where we, unlike even in Western countries where we put a speculum in for any children with abnormal discharge or with these symptoms. But in India, we try to, we try and refrain from doing a vaginal examination. So we can do we can give a swab to the girls themselves and ask her to take it. But initially we have to gain confidence and slowly proceed. So detailed history is the main thing. Adolescent children should be seen alone, and we have to promise confidentiality, and then symptoms, and encourage them to tell their parents, because this will lead to long-term sequelae. So we have to explain all these things to the patient. Symptoms are usually dull aching, lower abdominal cramps, and usually it is bilateral, but rarely it can be unilateral also. And it's a constant dull aching pain less than 7 days after the menstrual periods. And pyrexia, some of them present with severe PID, they present with pyrexia more than 30 degrees, mucopurulent discharge, rebound, lower abdominal tenderness, involuntary guarding, cervical, again the cervical motion tenderness, only women, older women, we can elicit this. That is why it is tricky in adolescents. So we should have a lower threshold to start the antibiotics if we suspect PID. So then adnexal tenderness, uterine tenderness, cervical motion tenderness, it is 95% sensitive. And there will be adnexal fullness with the TO abscess, tubo-ovarian abscess. So the diagnosis is mostly clinical, with a positive predictive value of 65 to 90% and higher PPV among sexually active women and girls. Combination of history, physical examination, and laboratory tests is necessary to come to arrive at a diagnosis. and low threshold for treatment, especially in young girls and women who are sexually active. If one or more criteria, that is adnexal tenderness or uterine attendant cervical motion tenderness is present, better to immediately start the antibiotic after taking the swabs. So they can present with right atypical presentations or right upper quadrant tenderness with jaundice. So Fitz-Curtis syndrome due to chlamydia trachomatis. All of us would have seen in the laparoscopy, diagnostic laparoscopy, when we want to arrive at a diagnosis or to evacuate abscess, drain the abscess. Then there is a prospective cohort study with 117 adolescents, 4% incidence of this Fitz-Curtis syndrome in even mild to moderate PID. Sensitivity of the pelvic examination is 60% and empirical treatment is indicated. So differential diagnosis. So we have many other conditions which can mimic PID. Ectopic pregnancy, we have to rule out, and appendicitis is another similar thing. But here in practice, if we do a vaginal examination, if it is not tender, then obviously, and when we do a bimanual palpation, if there is no cervical motion tenderness, we can clearly exclude acute PID. And then if it's still there is right iliac fossa tenderness, then it will be most probably appendicitis. And that can be confirmed radiologically. So because that is a common referral for us. And cervicitis is another condition which we have to rule out, and urinary tract infection, endometriosis, ovarian torsion, interstitial cystitis. So all these has to be excluded. So no single test is highly specific and sensitive, but lab imaging and other procedures increase the specificity. Elevated white cell count more than 10,000, CRP more than 40, and microbiological diagnosis. Three swabs are taken, and they are taken from the cervix endocervical sampling during speculum examination. One is a direct for examination, GMs are staining for, and the second one is sent for culture for Neisseria gonorrhea, and the third swab for NOT techniques for chlamydia trachomatis, Neisseria gonorrhea, and Mycoplasma genitalium. So the additional tests we need to do are the test for syphilis, other STIs, hepatitis B, hepatitis C, and HIV, and routine urine examination to treat the concurrent UTI, and urine pregnancy test. Of course, that is the first thing we should do in any woman with any girl for that matter. We should do, whether they disclose the sexual history or not. We have to do, if they come with abdominal pain or irregular vaginal bleeding, we have to test for urinary pregnancy test. And recurrence and follow. And the other modalities are ultrasound and MRI. But they are non-specific. MRI actually it shows bilateral hydrosalpinx, but we do not do routinely unless it's a complicated type of PID and the patient is very sick and we do not know the cause. So the recurrence and follow, there is 15 to 20% of recurrence. And how to follow the patient? It is best to have personalized text messages, and it gives better compliance. Since I practiced in the UK, it always helps when you call them. And even in Tirunelveli, we usually call them for follow, especially the young girls. We give them a particular date and ask them to come back, and they do come back if we are very personal and. So the NOT of vaginal samples to evaluate gonorrhea, use of barrier contraception, screening for STI prior to IUCD insertion, and the risk of ectopic pregnancy needs to be explained. So the management protocols are in the FOXI guidelines, but there are treatment regimens which are outpatient and inpatient regimens, and it is polymicrobial, so we have to use broad spectrum antibiotic. So mild and moderate symptoms we can treat as outpatients, but the follow-up needs to be emphasized. Within 72 hours, we have to see them again. Aim for symptomatic relief. Pain relief should be there. Treatment of acute condition. Anti-inflammatories we can give. Prevention of sequelae. Rest in cases of severe PID, we have to admit them. Fertility is well preserved if the first episode with prompt antimicrobial therapy. So outpatient treatment, azithromycin, mild to moderate infection, compliance is better. For 5 days, we can prescribe. And ceftriaxone 500 milligram IM single dose along with doxycycline is a standard dose, 100 milligram BD with metronidazole 400 milligram BD for 2 weeks. In case of penicillin allergy, clindamycin can be used. Again, in older women, we can use the ofloxacin or
Ma'am, sorry to interrupt you, ma'am, but your time is up, ma'am.
Okay, I'll quickly, two more. So the outpatient treatment is then a criteria for inpatient management. Again, the surgical emergencies, tube ovarian abscess, severe illness, unable to follow or tolerate the outpatient. So the recommended dose, it is in the CDC guidelines. So the ICOG recommendations, augmentin with doxycycline can be given. And regarding the counseling follow, as I said earlier, 48 to 72 hours, we need to see them back and return information should be given. So severe symptoms, we have to admit them. And if we cannot arrive at a diagnosis, laparoscopy is indicated. So the parental regimens, it is given in ICOG guideline. Clindamycin and gentamicin is used in some cases. Alternative regimens recommended oflox, but in adolescent children, better to avoid quinolones, and then they can affect the bones, growth of the long bones. So the follow resolving symptoms and signs favorable, compliance with oral antibiotics, screening and treatment of sexual contacts, awareness of the significance of PID, and full screen for all STDs should be done. And test of cure should be taken 72 hours. And in case we are using it is after the not, then after 6 months, we have to repeat it. Primary prevention is knowledge is power. So we have to explain comprehensive sex education is the main key to prevent PID in young adolescents. Reproductive health, contraception, about childbirth, STIs, including HIV, importance of menstrual hygiene should be reinforced. Safe sexual practices. References ICOG, FOXC and CDC guidelines. Thank you so much for the opportunity. Thank you, Sampath ma'am. And thank you, Vidya Tobi ma'am.
Thank you so much, Radhika.
Thank you.
Yeah, thank you. Can you please stop slide share? Again, since we are short of time, we'll progress further. Requesting all speakers, number one, to please stick to their time limit. And secondly, please check the chat box. If there are any queries, do answer them. Also, there is a question put that if the pre-test is missed, is it required for the certificate? The post-test is compulsory. You have to fill it up. Pre-test, we may make a little consideration. I'll now move on to the next session. And again, Vidya ma'am, I will request you to introduce the next chair.
I want to thank Dr. Radhika Gauri. She has given a very excellent talk on pelvic inflammatory disease in adolescent. I think we have to focus on the primary prevention as well as the secondary prevention for screening of the infection and the effective treatment of these pelvic inflammatory diseases in adolescent to have proper treatment and consequences we can prevent. I think Dr. Ranjana is also staying back with me. So, yes. But it is a very, my pleasure to introduce Dr. Rajal Thakkar. She is also my dear friend who is a professor at Srimati NHL Municipal Medical College, HCL Hospital. Ahmedabad, and past president of AOGS and 2018 to 19, 20 to 21. She has got a lot of accolades to her credits and so many awards, and we know her work in the commendable work in the adolescent group. So I would love to listen to Dr. Rajal Thakkar. So
thank you, madam.
Welcome, Rajal ma'am, once again with saluting your spirit of fighting.
Yes. She's a fighter also.
Over disease. So please do continue with your talk, madam.
Yeah. मेरा screen share कर दिया? Yeah. Is it seen?
Teenage pregnancy.
Yes, ma'am. Yes.
It's seen. Okay, fine. So, very good evening, dear friends and respected seniors. Greetings from Ahmedabad. After a long time, we have a little rain this evening. Thank you, team ICOG and Foxy, for giving me this opportunity, and thank all my well-wishers and friends and for your prayers during my fight of I'm battling with my CA pancreas. So thank you very much, and I'm looking forward to be normal as soon as I possible. The session outline would be definition and statistics, why we are worried, causes and strategies and management. Now the topic given to me is teenage pregnancy, but better we call it as an adolescent pregnancy. So adolescent pregnancy is, just a second because I can't see my slides. Okay. Adolescent pregnancy is the one where it is a pregnancy in a girl of 19 years or less. This is my reference of the key facts by WHO. And as per the WHO, in low and the middle income countries, estimated 20 million pregnancy each year. And out of these, 50% are unintended, resulting into 12 million births. And out of these, 55% are unintended, leading to either unsafe or illegal abortions. The trend of adolescent pregnancy or the teenage pregnancy is decreasing over a period of past 20 years. But we should be happy that there is a sharpest decline in Southern Asia, including India. But then there are certain countries where there is a very high rate, like Sub-Saharan Africa, and in European region it is 13.1. And lots of difference between regional difference across the world, in the country or within the country, and in the vulnerable groups and uneducated and unmarried ones. So if we see this chart, in Sub-Saharan Africa, about 25%, these are the percentages. In Southeast Asia, 10%, and these are the adolescent pregnancy percentages. Globally, almost 1 in 6 and 1 in 4 young women, because it is a 25% in Sub-Saharan Africa. So 1 in 4 young women give birth before the age of 18 years. These are the countries where African countries and Southern American countries, lots of incidences. And top 10 countries are, this is the list. We don't have to remember, but at least the countries in Africa and South America are giving higher rates of teenage or the adolescent pregnancy. We should be knowing our data of National Family Health Survey. Recent one is the 5th, 6th is data yet to come. But then if we see the marriage and the fertility, women age of 15 to 19 years who were already mothers or pregnant at the time of the survey, this is the data of NFHS 5. So urban is 3.8%, 7.9% is the rural. So overall total is 6.8% of the women were pregnant at the time of the NFHS 5 survey. So still it is decreasing, but still there are incidences and the girls who are getting pregnant at a very young age. So there is a decline, but it has not matched the developed countries. So why should we be worried? Because there are lots of issues. Because girl is still growing, and at the same time there's so many issues related to her health, illiteracy, poor socioeconomic condition. She is not empowered. Education is not there. So more problems. So problems in the antenatal period. So unintended pregnancy might go for unsafe or the illegal abortion, hypertensive disorders. This is maybe because this is the first pregnancy, and the eclampsia and pre-eclampsia are more common in first pregnancy. So it may be the first pregnancy, or it may be because of the adolescent age group, anemia and the nutritional problems, antepartum hemorrhage, STI, and higher severity of malaria. During labor, because she's still growing, there is obstructed labor. If there is a home delivery, chances for fistula and birth injuries, preterm birth and increased rate of C-section. In the postpartum period, there is anemia, postpartum depression, too frequent pregnancy because she cannot decide about the contraception, and risk of eclampsia again in the postpartum period, puerperal endometritis, systemic infection compared to the age, elderly 20 to 24 years. If we compare the disability affected life years and mortality globally, top 5 causes of DALY and mortality is higher in the age group of 15 to 19 years. Highest mortality amongst the age of 15 to 19 years compared to 18 to 25 years. In Southeast Asia, the recent data about 6,500 die every year because of giving birth. So again, when she is unmarried and then she is not having any access to the education, job skill, there is no job. She is not educated. She is not financially independent. She is living the poverty, and pregnancy itself is a challenge for her and her family. So she and her child are going to suffer. Maybe she's stigmatized because she is having unmarried socioeconomic condition. The family is outcast from the society, and maybe she is not going to the government hospital. Then the care of the cost is very high. And if we see, if we compare between unmarried and the married one, then the married one more likely to seek the medical help compared to the unmarried one. But in the long term also, chronic ill health, depression, inability to raise the child, etc. These are the main problems amongst the both group, married and the unmarried. Then for the baby, so low birth weight, preterm babies, perinatal and neonatal mortality, inadequate childcare, breastfeeding practices are also inadequate. And one of the paper that I was searching, this was like congenital anomalies are also common in form of CNS, gastrointestinal and musculoskeletal system because of it is some correlation between low BMI before pregnancy, folic acid and other multivitamin deficiency may lead to all this congenital malformation. Maybe the unwanted child being thrown out recently at Ahmedabad also, and then we do get some news of the baby being thrown in the garbage or etc. And the child which is growing up having also nutritional problem and stunting and other socio and biological problems occur. They live in poverty, the girl is unmarried, there is a victim of neglect and abuse. Maybe the baby is neglected in the orphanage, involved in a crime, and drug abuse and alcohol, etc. can happen. Now coming to part 2, what are the causes? Ultimate cause is the unprotected sex and early initiation of activity. So let's see, these are the factors, are the socio-cultural. So we see one by one, so I'm not reading one by one. So socio-cultural, society is to be blamed. Early marriages, early pregnancies, early motherhood. As per WHO, worldwide there are 650 million child brides. Indian data, about 4,000 per day, 16 lakhs child marriages per year. And that lead to lots of issues. And reason we all know, because of the poverty, patriarchal society, unable to, because of the insecurity, keeping the young girl at home and the parents are going for work, lack of education and etc. And implementation law is also not strict at places. So again, remember these women aged 15 to 19 years who were already at the time of survey were 6.8% in India. If we compare the NFHS data, it is decreasing the child marriages across India, but still they are happening. These are the top state in India in red are having higher child marriages: West Bengal, Bihar, Tripura, Jharkhand, Assam, Andhra Pradesh, Rajasthan, and Telangana. And these are and then once they are married, they don't have the decision power. The husband or the mother-in-law decides about the next pregnancy, about the usage of contraception, and lack of economic independence. Urbanization leading to the families which are having nuclear, so children are being raised without parental control. We do get patients at the medical college hospitals they know that the law is there about less than 18 years, so they will write down 20 years and then we have to estimate the age. Same happens for the MTP also, that it is our duty to ascertain the age of the patient. So this happens. More opportunities, the girls are staying in the hostels, boys are staying in the hostel without parental control. They are having their job in the cities and having more opportunities to mix with their peer groups. Unprotected sex under the influence of drugs and the alcohol, they are not aware of the contraception. Certain our festivals like Navratri, even in Gujarat and other places, in Nagpur, somewhere these are the news. They have the late night, they are out even on the Valentine Day. And these are the things that can happen. Now, which are the biological factors? The teen brain is still growing. It is still, there are neurological stress, and it is still the brain is processing. and leading to the amygdala is having a still it is being getting developed. So fight and flight response is different. They are confused. They have less capacity to understand. And we all know these teen characters that they have curiosity, experimentation, peer pressure, that they don't know about the consequences, and they have poor negotiation skill. So all these lead to drug abuse, early sex, and unprotected sex. And they have the multiple partners, maybe different kind of sex having, and with the internet, they have this all access to the pornography and sexting, and then meeting all different kind of people online in the social media. Age of menarche is also decreasing. So long time of getting periods and then getting married, and then there is lots of opportunities to have it to unprotected sex. Lack of excess ignorance about the sexuality. Already Apurva has given much detail. And we had one patient she was an 11th standard girl. She did not know. She had read about the pill 72, but then she thought that once taken, it's done. But she has a half knowledge. She was not knowing that every time she has unprotected sex, she has to have the emergency contraception pill. So half knowledge. 23 millions have unmet need of contraception. Even in India, if we have the total reproductive years, total unmet need is still higher, 9.4%, and still some of the research papers have come. And very low contraceptive, unmet need is very high. Condom use at first intercourse is also very less. Boys are also not using. So we need to, and influence of the media already more. There are few serials that were on air on television, and these are the serials that promote. The boy was only 10-year-old and he got married. Then Balika Vadhu, all of us have seen, and then so we need to protest about that. They have been watching pornography and the TV, and then they initiate into this early sexual activity. Pornography also, they may lead to unprotected sex. And then this is a release of dopamine, and this is a burst trap of substance, sex, and technology. And they end up into pornography, sexual violence, large number of women under the age of 18. And many of us also have, some or other source of even the verbal abuse while going to the school, while in the bus, while in the theater. This is very, very common. And the rape by the seniors or in the family members, and the service delivery factors that they don't know where to go. Even the married adolescent, they don't know, hardly go for the antenatal care, or unmarried, so they hardly go because they are, stigmatized by the society. So service delivery factors, so they need to go to for the treatment. And already Apurva has clearly mentioned in his talk, so I'm not going much into detail, but then adolescents are having their own reserves for going to the hospital, being examined by the male doctor, or maybe they feel that they will be judgmental, there will not be privacy, confidentiality, the clinics are not good for them, they perceive they are afraid of the surgical procedure and etc. So they are not going to the distance and the cost. They may be having their college and they can't go to in the morning hours. So, and the policies are also like that, we have to make the policies where the adolescent boys and girls, and we need to have the clinics as per their requirement, as per their timing, as per their suitability. So coming to the end, third part and the last part of my lecture, that we have seen the causes, we have seen the reasons why it is happening. So we have to prevent it so that lot many problems can be prevented. So what are the management and the prevention policy? There have been, we start from above downwards, the international agencies, and we go one by one. So international agencies, the WHO and the Sustainable Development Goals, we have to finish it by, achieve it by 2030. And these are the 17 goals that have been described. And this is the priority of adolescent pregnancy and childbearing and prevention of child marriage. These are with having their indicators. So, end poverty, so that will prevent the child marriage. end hunger, achieve food safety so that and security, so the nutrition is good, ensure healthy lives and promote well-being, and adolescent birth rate should be less. So these are the indicators. If you want to go into detail, I'll take 2 or 3 minutes more. Is that okay, ma'am? 2 to 3 minutes more.
Okay,
Yes, ma'am, you can wind up in 2 minutes. Yeah.
Okay, fine. So these are the sustainable goals that are there. Even the WHO Southeast Asia having this goals that we need to achieve. Our government having the current program is the Rashtriya Kishore Swasthya Karyakram, under which there are several titles, and one of them is on the healthy lifestyle, violence, and nutrition. These are the clinics already Sampath madam has done, and we have been happy to part of this AFHS project with Swedish Lund University. We have to be the adolescent friendly attitude with maintaining the privacy and the friendly clinic. The government program should have the linkages so that not only we have to focus on the teenage pregnancy, but the other programs to empower them. And or we all know about the Beti Bachao, Beti Padhao, Bete Ko Bhi Samjhao. We have to take care of even the Mann Ki Baat, Modi ji has told about the empowerment. The strict implementation of the Child Marriage Act, also already told that these are the decreasing trend. Pornography is also government is watching and disabling many sites also. We need to inform where the services are available. We need to inform about the parents and the guardians. We need to create about the consequences of the adolescent pregnancy and the counseling. Even at our own level, if our household servant is there, we need to counsel that कि आपकी लड़की है तो उसको पढ़ाओ लिखाओ और उसकी शादी 18 के बाद कराओ. Even the role of religious leader is very, very important because they have very much influence on the society. The NGOs also, and I had a privilege to work with Seva. This is myself with the Ban Ki-moon, Ilaben, who is she is no more now, but owner, heading the Seva NGO, and Rani Bang. So they are doing a lot of work across India, and I'm sure that in your region, there will be many who is working awareness programs. And these are the programs which were aired on, and then there was lots of outcry. So we have to raise our voice. The role of media also, role of the celebrity, because when they say there is a major impact on the society, even for the boys also, that they need to be just to be, very careful about respecting the women. Even Deepika Padukone has recently said that कि बच्चे को भी लड़के को भी housework सिखाना चाहिए. We should not forget our own ICOG and Foxy because they are having similar kind of this training programs. Members are doing lots of healthcare activities, and the training programs are there, and adolescent committees lots of doing lots of work. The parental role is parents needs to talk to and the communication is very, very important. We need to have the research because working at a medical college, we are doing lots of research. And recently, one of my residents is having a dissertation on teenage pregnancy. Few of the publication that we have done on so similarly, we all are doing our work. We need to have the life skill because just as environment projections start with me, we individually, we can do some kind of life skill education. Na ka matlab na hi hota hai, and we all know these dialogues from the movie Pink. And we need to say that they learn to say no. The girl should be a strong self-esteem, defense, and need to counsel, advise, and they have to share sorrow and the joy. And we need to catch them young and teach them right. Thank you very much for the patient hearing, and I hope I have given enough justice to the subject. Thank you very much, and once again, thanks for inviting me.
Thank you so much,
ma'am. Ranjana ma'am, will you please like to sum up the session?
Yeah, thank you so much, Dr. Rajal. It was a very good talk, and I basically feel that the root cause of all the trouble is uneducation. So it is very important to educate our girls, and broken homes is also very much responsible for this. I have done a lot of work in adolescent health, and I used to go to schools, and we used to give all the girls slips, so that they could not write their name, but just write their problems. And I was horrified when I came to know that girls are being sexually abused in their own homes by their own fathers. So it was really distressing to know all that. So at the end of the day, we have to educate them, and we have to, actually teach them the right path. So that was an eye-opener, your talk. And yes, I have also had a lot of experience in this. We used to go to so many schools. And Sampath has been doing so much work. And now, before I say a big thank you to Sampath for the invite and Supriya for the reminder, I would like to just request all of you that I'm standing for President Foxy, and please do give me your vote and support. Thank you all so much.
Thank you so much, ma'am. Thank you, Vidya ma'am and Ranjana ma'am, for chairing the session. And immediately we will move forward to the next session. Meanwhile, I request all speakers once again, once your talk is done, please do check into the chat box. If there are any queries regarding your topic, please do solve them. And also all the delegates, please do fill up the post test. So now I will request the chairpersons for the next session. I'll invite them. Dr. Panaliyappan cannot join because he's busy. So let me welcome Dr. Alka Pandey ma'am, Professor and Head of Department, Professor Department of OBGYN, Narayan Medical College, Saharsa, ex-Associate Professor, Department of OBGYN, PHCH, Patna, Vice President Foxy, 22-23, and now the Governing Council member of ICOG, organizing chairperson of the Foxy Vice President Conference 2023. It's an honor to meet you, madam, and I'm hoping to meet you also in Patna in person. Next, I would like to invite Dr. Meena Samant, Senior Consultant and HOD, Department of OBGYN, Kurji Hospital, Family Hospital, Patna, President Patna OBGYN Society 23-25, and Governing Council member ICOG. Again, madam, hoping to meet you too in the Patna conference. And over to Dr. Radhika Gauri for the next session.
Thank you, Dr. Supriya ma'am. I have the opportunity to welcome Dr. Supriya Arwari for the next talk. She is the consultant obstetrician and gynecologist and infertility specialist from KEM Hospital and Wardia Maternity
The
Hospital.
chairpersons are there now.
Request the one of the chairpersons, they can introduce.
Alka madam is there.
Yes, I think Alka madam, Meena madam, both have
Both are
joined.
there. You can ask one of them to introduce.
Okay, ma'am. I request Alka ma'am to introduce our Dr. Supriya Arwari ma'am for the next talk.
Okay. Thank you very much, Sampath, and all the organizers of this certificate course for giving me this opportunity. And now I'll introduce Supriya.
Ma'am, 2 lines to you. People have been hearing me the whole day yesterday and today, so I think it's quite okay.
So she is the national coordinator of Foxy Adolescent Health Committee and vice president of Thane Obstetrics and Gynecological Society. And
I think, ma'am, that
what?
Yeah.
Gold medalist, recipient of AMOX, V for Stree Puraskar, and Dr. Anandi Bai Gopal Joshi Award for meritorious service by female doctor, IMA Maharashtra State President's Appreciation. And she has won the title of Mrs. Iron Lady.
Thank you, ma'am.
So, thank you so much. Founder, chairperson, Women's Wing of the Indian Medical Association of Bhiwandi. So, she's a very efficient person. And now we are going to hear her talk.
Thank you, ma'am. And I will share my slides.
Yes. So, let's hear your talk.
I hope my slides are visible.
No, abhi to nahi.
Nilima,
Yes.
you have to stop that process.
No, I will. It's my end only, madam. I'll do it. Yeah. Okay, so I'll try to stick to time. I'll request the ICOG backend to please remind me when my time is up, because again, this is a huge topic and to cover it over 15 minutes is going to be tough. I'll be talking about puberty, especially puberty related to precocious and delayed puberty. Little bit about puberty, the normally what puberty entails is puberty is a developmental stage during which the child becomes a young adult characterized by the maturation of the gametogenesis, secretion of gonadal hormones, and development of secondary sexual characters and reproductive functions. So in short, a young child is now being converted into a person, a male or female, who is likely, who is, who has the right or the capacity to reproduce. And this is what exactly puberty means. So it's probably a transition period between absolute childhood and adulthood. This is again, a brief chart about how puberty takes place. So we have the gonadal development and the adrenal hormones which are secreted, adrenarche, which will cause the growth of pubic hair, axillary hair, particular pubic or body odor, receding of hairline in males, and the gonadal development of gonadarche, which will produce GnRH in females, FSH, LH, leading to breast development, menstruation. In men, testicular enlargement, enlargement of the secondary sex characters. So, basically, it is the pulsatile secretion of the gonadotropins which occurs under the influence of the hypothalamic GnRH and is responsible for all the secondary changes in the gonads, sex secretion of the sex hormones, and appearance of the secondary sexual characters. The primary hormone responsible for onset of project and progression of puberty, that is the hypothalamic GnRH. Why I stress it here is because it plays an important role in management of various types of either early or delayed puberty. The various stages that are present in adolescence or during the puberty stage, first and foremost is thelarche. Now I'm talking about the girls here, which denotes the onset of breast development. This usually starts around 2 years before the onset of menarche and is due to the estrogen effect. Pubarche denotes growth of the sexual hair, that is hair on the pubic area, your hair in the axilla due to the androgen effect. And this is 1 year prior to menarche, and menarche actually indicates onset of menses. And in men, it is the spermarche, that is the appearance of spermatozoa in the cervical follicle. So this is the sequence I have already mentioned, that first the breast bud will start. This is the first sign of puberty. This is followed by pubic hair. After that, after pubic hair, within an interval of 1 year, usually the menarche starts. Height growth starts during this stage, and the peak height velocity occurs early in the part of the puberty and usually precedes menarche and can continue up to around 18 years of age. This is the staging of breast development, the Tanner stage. Now, I have no time to go into the details, but I would just like to show the flow charts to those who are interested. This is the breast development. This is the pubic hair development. This is again the pubic hair development and growth of external genital characters in boys. Now, what exactly is precocious puberty? Now I come to my definition. Precocious puberty is puberty starting before a statistically specified age, 2.5 SD below the population mean. Now, this is very nice to look at on paper, but what exactly do we mean by 2.5 SD below population mean? So on an average, among girls, breast and sexual pubic hair development before the age of 8 years or beginning of menses before the age of 9.5 years is termed as precocious puberty. However, in recent times, in view of the decreasing age of menarche in girls, the latest guidelines state that it's considered as precocious puberty if breast development begins and pubic hair, of course, development begins before 7 years of age in the white or the Caucasian population and before the age of 6 years in the black or the Afro-American population, African population. I think the Asian population will lie somewhere in between these two. Among boys, testicular enlargement more than 4 ml or pubic hair stage 2 before the onset of, before the age of 9 years can be labeled as precocious puberty. Now, there are two types, that is the central and the peripheral precocious puberty. The central type is the true precocious puberty. It is gonadotropin dependent, usually isosexual, and increased estrogen or testosterone with pubertal FSH LH is noted, and pubertal gonadotropin response to GnRH stimulation test will usually be positive. In the peripheral or the peripheral precocious puberty, also called as the pseudo precocious puberty, wherein I will go into the details in the next few slides. These are the various variants, that is, apart from central precocious puberty, if we have peripheral precocious puberty, it can be premature adrenarche, premature thelarche, and in central precocious puberty, which is the more important and the commoner form, is what I'll first describe. Already I have mentioned onset of secondary sexual characters, development before age of 8 years in girls, and onset of testicular development or pubic hair development before the age of 9 years in boys, 5 to 10 times more common among girls rather than boys. 90% of the times it is idiopathic, and especially in the girls. Among the boys, 75% of the cases can be due to structural CNS abnormality. Clinical presentation, there is sexual development. This may begin at any age. There have been noted at as young as 2 or 3 years of age. In girls, menstrual cycles will be more early onset and irregular. Initial cycles, of course, are usually anovulatory. In boys, testicular biopsy will show stimulation of all the elements of the testes, and spermatogenesis observed in boys as early as 5 to 6 years of age. You can see here, there is literally toddlers and infants who face precocious puberty with development of secondary sexual characters at a very young age. Prevalence, already I have mentioned, some more common in females, 1 in 5,000 to 10,000. And clinical features, similar to those of normal puberty, but at an earlier age. So there will be thelarche followed by pubarche followed by menarche, but at a very young age. Mood swings and mental disturbances are more common because these children are very young. They cannot understand what exactly is happening to them, and therefore they are ill-equipped to deal with puberty. As such, we know adolescents, even at the right age, are ill-equipped to deal with puberty. You can only imagine what happens with the younger children and what must be the condition of their parents. So there is irritability, oily skin, sudden growth spurt, underarm hair growth, and adult body odor. There may be some features of central nervous system lesions depending on what are the causes. Of course, secular, racial, and ethnic differences are definitely going to be there. Now we have the gonadotropin dependent central precocious puberty, that is mainly because of the HPO axis. And then we have the gonadotropin independent, that is the peripheral puberty, precocious puberty, wherein all these syndromes like the McCune-Albright syndrome, autonomous ovarian cyst, ovarian tumors, feminizing cortical tumors are all come under this heading. However, the central precocious puberty, we usually have the hypothalamo-gonadotropic axis active deviation. There may be organic brain lesions or hematoma, hydrocephalus, severe head trauma, something, sometimes after some road traffic accident or such. And there may be, of course, the idiopathic and genetic causes. Outcome or the consequences in almost half the children, the pubertal manifestations will regress. Now, this is something which is important. So in the initial part, we may, wait and watch for some days to see whether the pubertal manifestations halt on their own. But if not, if they continue to progress, then we need to treat. If they, however, they stop progressing, we can just wait and watch. In progressive precocious puberty cases, what are the main concerns is that because of early epiphyseal fusion, the child will attain shorter adult stature than what would be expected if the child got a puberty at the normal time. there are going to be adverse psychological outcomes, early menarche, very difficult to predict when it will start and how the child will cope with it. Height loss due to precocious puberty is inversely correlated with the age of onset of puberty. Now, how will you assess this patient? Primarily, a detailed history, especially whether there is any familial tendency of precocious puberty, onset, duration, and progression, age at the onset of puberty in parents and siblings, very important. History suggestive of any CNS dysfunction, any history of convulsions, any history of road traffic accident, any history of head injury in the past, or maybe hydrocephalus, and a growth record in general. Examination wise, anthropometry to be done, especially because these children, we will not be able to assess the age just by observing them. So it might be important to establish the bone age. Tanner staging, especially of the breast in girls, the pubic hair in both boys and girls, and the external genitals in boys. Central nervous system examination, cutaneous markers for certain syndromes, and a per abdominal examination, especially for any masses palpable, because as we know, ovarian masses, ovarian tumors can lead to precocious puberty. Girls with breast stage 3 or higher, we will definitely, label them as precocious puberty. If they are breast stage 2, but with other additional criteria, like increased growth velocity, like CNS dysfunction, like cutaneous markers, then definitely it will be a feature of precocious puberty. And in case of peripheral precocious puberty, there may be some isolated markers like isolated thelarchy, isolated pubarchy. So that is what we need to note. When the clinical features are inconsistent with the progressive nature of precocious puberty, the best policy is wait and watch for a few months and perform a reassessment, maybe after 3 or 6 months, to avoid unnecessary evaluation and treatment. Evaluation of central precocious puberty, I've already mentioned anthropometry to measure the bone age, certain biochemical testing, a pelvic ultrasound, mainly to rule out any ovarian tumors, germ cell tumors, MRI of the brain to make sure we are not dealing with some intracranial lesion. And in case we suspect so, then genetic testing, hormonal measurements, morning level of sex steroid should be determined, acid detection limits adapted to pediatric values. That is important because often we are tuned to reading adult values. E2 levels in girls, although it has a low sensitivity, it can still be done. Very high E2, that is generally it indicates an ovarian cyst or tumor. Gonadotrophins central to the diagnosis. Now, this is something that is important. And suppressed levels of LH with elevated sex steroids will suggest peripheral precocious puberty. Random measurements of LH is not very informative unless clearly elevated, and gonadotrophin, that is LH levels after stimulation of the GnRH stimulation test is the gold standard for this test, where the peak LH values of 5 to 8 international unit per liter will suggest progressive central precocious puberty. So just briefly about the GnRH stimulation test, how we can do it. So we can give leuprolide 20 micrograms per kg subcutaneously, and after 2 hours and maybe also after 4 hours, measure the LH. The same test can be done with triptorelin 100 micrograms subcutaneously, measure LH after 2 hours. LH level more than 5 international units per liter suggests pubertal onset, favoring central precocious puberty. Bone age, nothing much to dabble into. The radiologist friends will help us with it. Ultrasound scans, already I mentioned, to rule out ovarian tumors, to check for the uterine changes, whether uterus is also developing in conjunction with the growth in the ovarian size, whether the endometrium is growing consistent with puberty. A uterine volume more than 2 ml, that length more than 34 mm, has been reported to have around 89 or up to 90% sensitivity and specificity to indicate precocious puberty. So this is a very simple thing that can be done in ultrasound itself. MRI in cases of, especially in cases of progressive central precocious puberty, whether there is any hypothalamic lesion or any brain lesion that is causing the precocious puberty. This is a very, very busy chart which shows a differential diagnosis of precocious puberty. Actually, whatever I've spoken till now this is shown in this slide. So in case you all want to take a screenshot and maybe study it a little later. What is the treatment now? Having diagnosed, we want to treat. Oh, is my time up already? Okay. I think I'll wind up in another 5 minutes. Yeah. So GnRH agonists work by providing continuous stimulation of pituitary gonadotrophins instead of physiologic pulsatile stimulation from hypothalamus GnRH. This leads to desensitization of the gonadotrophic cells and suppression of gonadotrophins. So what are the various preparations? We can give leuprolide acetate. The recommendations are based on body weight for 4-week formulations. So this is a chart which shows usually leuprolide acetate 11.25 milligram per 3 months. So, given the convenience of giving every 3 months, you can also give the 7.5 milligram for more than 2.5 kg, for more than 25 kg on a monthly basis. Triptorelin 3.75 milligram monthly basis or 11.25 milligram every 3 months. Monitoring of the child. Now we need to monitor the.
Ma'am, your time is up, ma'am.
Yeah. I'll wind up in 5 minutes. Yeah. Okay, so height, growth velocity needs to be monitored. Biochemical thing about the LH, the bone age needs to be studied. How long do we have to give the therapy? Well, we can give it up to 8 years of age. I'm going to skip these peripheral precocious puberty things and go directly to delayed puberty. But how long to continue therapy? Continue up to 8 years of age in the girls and maybe 9 years in the boys, after which we can stop the treatment and allow the child to progress into normal puberty. Of course, even after stopping the treatment, the patient will have to be monitored. Safety concerns about LH, about GnRH, there might be some questions in the minds of the parents. So we can definitely assure them that the therapy is fairly safe. It does not affect future fertility, because that is something again which people would be worried about. So just quickly about precocious puberty: onset of puberty before 8 years in girls and 9 years in boys. Central or peripheral possible. Idiopathic brain tumors, hydrocephalus, hamartoma, McCune-Albright syndrome will cause the peripheral variety. Risk factors, ethnic varieties are possible. Exposure to sex hormones, radiation therapy possible. Complications will be shorter height, early bone ossification, social and emotional problems like maladjustment and depression in the child. Also, child sexual abuse is a real danger. Let me go quickly through delayed puberty. Puberty is considered delayed if no secondary sexual characters are noted by age of 13, or if the menses are still absent up to the age of 16 in case of girls. In case of boys, if there is little or no genital growth by the age of 14 years, it affects around 3%. The etiologies are varied, but constitutional is the most common. So we have to take the history, whether there is any history of delayed puberty in the family itself, the siblings, the parents. The other causes can be hypergonadotrophic hypogonadism, where the gonadal damage due to secondary to chemotherapy, radiation therapy, or there may be some inborn errors of enzymes, androgen insensitivity, or ovarian or testicular dysgenesis. They can be the hypogonadotrophic hypogonadism. So in a male, abnormal testicles that do not produce normal levels of testosterone, or in females, abnormal ovaries that do not produce the required level of sex hormone estrogen. Gonadal failure, usually bilateral, because even if one gonad is active, they are likely to have puberty. So if both bilateral, in these cases, circulating levels of FSH and LH are going to be extremely high. So there are the congenital varieties like the Turner syndrome, Klinefelter syndrome, complete androgen insensitivity. There can be the acquired, like the chemotherapy, radiation therapy, post-infection, mumps, very common in our country, mumps, orchitis, Coxsackie virus infection, dengue, Shigella, malaria. The list is endless. Autoimmune and metabolic disorders to be kept in mind. Eugonadotrophic pubertal delay that is due to congenital anatomic anomalies. This is again something we have to keep in mind, whether there is an imperforate anus, hymen, whether there is vaginal atresia, vaginal aplasia. PCOS is known to delay puberty, although puberty eventually will occur, but we need to keep it in mind. Important for our country, things like malnutrition, hypothyroidism, hyperprolactinemia, growth hormone deficiencies. History, of course, like I mentioned, important, whether there is a delayed maturity in the family as such. Any clinical pictures, which describe any other endocrine disorder, periodic pain in the lower abdomen or something like an imperforate hymen, if can be seen, body measurements. I'll finish, yeah, the last 2 slides. Tanner staging and neurological examination, important. Treatment of delayed puberty, exclusion of serious hormonal disease or a chromosome variation to be done. If everything is normal, just simple reassurance and wait for the puberty to set in. Can we mute the rest of the people? Thank you. Delay, especially when accompanied by short stature, can produce anxiety, depression, low self-esteem, and isolation. As this is almost always a problem for boys due to difference in physiological timing, a short-term course of around 3 to 12 months treatment with low-dose testosterone can boost the growth and, pubertal progress. Treatment options include monthly depot testosterone esters for the boys. Testosterone usually continued until there is clear evidence of spontaneous puberty. Dosage and duration of therapy should be monitored, and especially there should be a team effort with a pediatric endocrinologist on board. Growth hormone not necessary unless there is a proven deficiency, and therapeutic management of simple delayed puberty is rarely required, especially in the girls, but low dose of ethinyl estradiol are the mainstay of treatment. Take-home messages, constitutional delay is the most common. Chronic anovulation like PCOD can be a contributory factor. Anatomic problems to be ruled out, especially imperforate hymen. Androgen insensitivity syndrome to be watched for. Hypergonadotrophic as well as hypogonadotrophic. Hypogonadism is something that we need to diagnose. Usually these adolescents present with lack of secondary sexual characters as well as the growth spurt, probably due to delay in activation of GnRH pulse generator. Patient may be started on low dose estrogen until puberty progresses, at which point the estrogen to be discontinued. During low dose estrogen therapy, not necessary to introduce progesterone withdrawal, because in early puberty, there is a similarly long period of unopposed estrogen prior to ovulatory cycles. In fact, it would be wise to give them for 3 to 6 months, give the estrogen, allow the secondary sex characters to grow, the uterine size and endometrium to thicken, and then probably give progesterone to, get the first menarche. So thank you so much. It's an exhaustive topic, and sorry for exceeding the time. I thank the chairpersons and everybody on board for a patient hearing. And I think we can go ahead with the next session. So can you unpin my video? Thank you. And I think without much ado, I will introduce the next speaker for the day. I will request the chairpersons to do the needful.
So,
yes, ma'am. Ma'am, Dr. Meena Samant, madam, is there. Alka, ma'am, would you like to make any closing statements?
no, you explained very well puberty, precocious puberty, and this delayed puberty. And let me know, delayed puberty, how long can you give estrogen and progesterone?
Madam, as mentioned, we have to watch for spontaneous signs of puberty and then stop. But now again, very difficult to measure. So probably we'll keep them, like I said, in very young girls, we can give, like if suppose she's like 16, 17, we can give for at least, because overall development is going to require estrogen. And if we start giving progesterone withdrawal too early, she may not get good periods, good flow, because the endometrial thickening will not have taken place. The growth of the uterus would not have taken place. So minimum 3 to 6 months of estrogen therapy, followed by 10 days of progesterone withdrawal. After that, we may want to wait for spontaneous menses, maybe watch for another 2 to 3 months. In case the periods don't occur, hopefully by then we'll have to rule out some genetic disorders, chromosomal aberrations, and something like that.
Okay, thank you so much.
Thank you,
It was a well explained talk.
So thank you, ma'am. And I'll request our next chairperson, Dr. Meena Samant, to please introduce Dr. Reena Wani for the next session. She'll be talking on POXO Act and MTP Act. Dr. Reena, are you signed up?
Yes, I'm there.
Yeah.
And unfortunately,
Madam,
this
Reena
is my
ma'am,
old
please unmute
CV.
yourself.
So,
Reena ma'am, please
Yeah.
unmute yourself. Meena ma'am, please unmute yourself. Meena madam, please unmute yourself. Oh, ICOG team, please see that Meena madam can be unmuted. I think she's trying to talk and
Yes, ma'am, she's posted, ma'am.
Yes, Meena ma'am, please unmute yourself. Not possible?
So I'll do that. I'll do her job and I'll introduce Dr. Reena Wani.
Okay.
She is Professor and Unit Head, SBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. Chairperson Foxy Perinatology Committee, 2015 to 2017. Then she is
thank you, Dr.
President,
Pandey. It's
Mumbai.
fine. I think we should go ahead with the talk. And anyway, this is my old CV. I will start with the talk if you allow me to share my screen. And thank you, team.
Yes, ma'am. Go ahead.
For inviting me
Reena.
here. I will share my
Okay.
screen. Yes, thank you.
Okay.
I will just share the screen. Yeah, thank you very much for the kind invitation. And I would like to share my screen. It's a pleasure to be here for this certificate course. And I have been like how Supriya also had to struggle to finish this talk in a short time. I will do my best in 15 minutes to cover. This is a vast topic given to me, POXO and MTP Act. And I'm going to briefly go through it with a few case-based illustrations. Through knowledge we shall conquer disease was a motto of Nair, where I spent 21 years, and now as head of department of Cooper, it is Arogyam Dhana Sampada. But everywhere we are giving priority to women from womb to tomb. The key points of the POXO Act 2012. Remember, there are 5 offenses covered by this act, but most important is the mandatory obligation. And the good thing is POXO has not restricted it only to hospitals. It is the media, hotel staff, hospital staff, clubs, a photo studio where you find there is something going wrong. Everyone is liable to do the reporting. One important difference in the POXO Act as compared to the previous acts was that anybody with the knowledge of something which is likely to be done to the child, it is failure to report which is punishable. But if the person who knows about it is a child, that is the only exception, that somebody who is below 18 is not going to be punished. Again, you must remember that POXO Act has redefined childhood as up to 18. Where there was a previous gray zone of 16 to 18 as per our IPC other code. Another thing, in the POXO Act, there are different section numbers. I won't go into detail of this, but I'm just going to highlight the important thing is that anybody who has given information in good faith shall not suffer any criminal or civil liability. This is to protect the person who's making the complaint. But if somebody has given a false complaint or false information, they would be liable if there's a problem. And as Yehuda Bauer has said, it's not just bad to be a perpetrator, not to be a victim, but above all, we shall not be bystanders. So these are the important things that have been included in the changes in the laws. It is not just a penetrative sexual assault, voyeurism, stalking, acid attacks, all of which are actually included. And under POXO, we have the definition of penetrative sexual assault, which has included not just the vagina, but mouth, urethra, or anus. This is also important. Aggravated sexual assault. This is when there's a person in authority. For example, the principal of the school, the legal guardian, the police inspector who is in charge of the station. These are all important things. And another thing, there are certain other specific sections which cover other areas. And here I'm highlighting the difference in the Indian Penal Code and the POCSO Act. Any touching also of the child with sexual intent is included under Section 7 of the POCSO Act. Whereas in IPC, there was more of criminal force or assault. Another thing is that I already spoke about person in authority. This is covered under Section 9, and the punishment is more severe for this. Another big thing which is covered in the POCSO Act is harassment, which includes something as simple as showing pornography with sexual intent or exhibitionism or threatening the use of pornographic media. Voyeurism, or when you have this, in fact, was a complaint I remember from Sion Hospital, where one of the boys was looking over in the bathroom of the hostel. This also can be considered under the act based on the age. Stalking, following or contacting is also covered under this. Use of a child for pornographic places or storing of media is also included, and this is important because we have to, even the photo studios come under the act. Section 16 is instigating a person to do something else. That means, if any of you have seen the Jodie Foster movie, where the bystanders who were aggravating that person to commit rape were also sued. Just an attempt, even if it has not succeeded, comes under Section 18. And very important, remember that in POCSO Act, we have expanded to include boys, because boys are also being sexually assaulted. Any person, male or female, below the age of 18, whereas in the Indian Penal Code, boys were not covered. And another thing is the accused or the perpetrator in POCSO has been expanded to be gender neutral. Both males and females, adult or child, can be the perpetrator under POCSO, whereas in the Indian Penal Code, it was only restricted to male persons. Again, the word survivor versus victim. We all know that we are not supposed to use the word victim because that is undermining the person and not giving credence to what she is saying. And the term survivor recognizes that the person is capable of taking decisions and we are not pitying that person. We have different presentations, and in pandemic, it was like a shadow pandemic in COVID because physical and sexual assault had really increased. In fact, since we became a medical college, we are actually the nodal department for sexual assault, and you will be shocked to see that, of course, we are following the standard protocols, collecting samples if the person has come within 96 hours, police referral, on-site NGO, and 6-monthly training. We had 1414 medico-legal cases over the past 9 years and almost 1,000 POCSO survivors and this is just the tip of the iceberg. We analyzed our data for last 3 years, from which I'm going to show you some examples to understand the nuances of POCSO and MTP Act and the dilemmas. This is just to show you the numbers and the graph. You can see that the graph is going down. Do you think it's because people are getting better? It's probably because there is more awareness and people are coming forward and more centers are being trained. We ourselves do training of all the peripheral hospitals so that anybody who sees them. Now here you can see this large number, 58% come under POCSO, which is a huge number. You can see that this was in the last 3.5 years. So the number we should not hide, that we have to be very particular, and unfortunately 41% of them required a termination of pregnancy or other care, which is why we have to have an algorithm of flow when the person comes to a healthcare facility. When she comes to a healthcare facility, confirm the gestational age, decide the indication of MTP, discuss whether it can be medical or surgical. If you require age proof, in fact, now you will find Aadhaar card in certain places we are not accepting as age proof because this can be manipulated. So the school leaving certificate or other documentation is sometimes asked for. And based on the information, get the informed consent of the guardian in Form C, complete the Form I, and then provide the MTP services. Now, this is just the flow chart. Now, this is the very important amendment of the MTP Act 2021. All of you are aware that this has really changed the face of our terminations of pregnancy. But you will find that we ourselves, being a referral institute, had 61% coming in second trimester up to 24 weeks. which is a huge number. So what are the dilemmas? Now, these are all cases of POCSO with MTP. 16-year-old unmarried who came at 27 weeks with history of assault. But this was too late because it was not possible to do it. We had to evaluate, brought by the police constable accompanied by her mother. So hence, it was not possible to do a termination. Only a court order would be required because she had come beyond 24 weeks despite the amendment in the act. But now, whether she should go back home or to an orphanage or to the child welfare committee, because it was the neighbor who was the assailant. Psychological implications of sexual violence and pregnancy. These are some things which we as doctors can't decide. This is an older case. I've just brought it up because it was one of the first cases which was all over the newspaper before our MTP Act amendment. Referred to us with anencephaly assault brought by an NGO because she had gone to 3 healthcare facilities and finally came to us in Cooper Hospital. And at that time, we had to take her to a medical board, even to abort an anencephalic fetus. But after that, now this was in 2016, you can see by the date on the newspaper. But now we are happy that these kind of problems don't come up. And there is a board at JJ, which is there in OPD number 18. This is another POCSO case. 15 years old with 15 weeks pregnancy on examination. But here the dilemma was she had gone to the hometown in Nepal where she was assaulted by the cousin. When she came back, she found she was pregnant and now she was in Bombay. Now, where do we register the FIR? Because the assault was in Nepal. So we had to get an FIR X. Email from the consulate of Nepal was required before we could do termination of pregnancy and then send the DNA report. Another one here, the survivor and the assailant are both under POCSO. 16-year-old brought by the mother, her boyfriend was even a year younger, 15-year-old boyfriend. But this was consensual sex, not accepted by POCSO. So, but here, both had to go to the child remand home and we went ahead with the pregnancy. She was brought with 2 months amenorrhea and we did go ahead with the surgical termination because the products were required. Because with medical termination, sometimes it is difficult to get the products for checking. Another case seen by a medical board had already been evaluated, went to an NGO and was advised termination with intracardiac injection. She came to us finally after roaming around 2-3 healthcare facilities with a high court order with the child welfare committee because these were the questions. They discovered this at 5.5 months. It was the employer of the mother who had assaulted this girl, but she had already passed that legal window. By the time she actually came to us, it was really too late. She was already 29 weeks. And this was the news article related to the same. And with consent, this is the picture of the girl and the mother. There were a lot of dilemmas, but finally we had to do a preterm cesarean section because she was getting breathless and the child was given for adoption. So these are all concerns. And this is one of the worst cases we dealt with, who had actually brought by the grandmother to surgery department with gas under the abdomen, free gas, no history of assault. But at laparotomy, we were called, hey, there is something abnormal with the uterus. And actually it was a case of unsafe abortion. The uterus was looking dirty, gangrenous with some spicules, but no consent, nothing, parents not available. We had to just do a wash and close and then find out. Unfortunately, this girl, later on, of course, she gave all this history and she was only 14 years old. But finally, we had to call the parents and do a hysterectomy to save her life. Otherwise, she would have died of septic abortion. So this is something which we have to look at. There's a conundrum between POCSO and the other laws. Ethical principles when we deal with these, autonomy, beneficence, and justice. I had a 16-year-old who was brought with the mother for delayed periods. And when I saw that she was pregnant and I told the mother, she said, it's impossible. She's never been stepping out of the house. Then there was this doubt of incest. And then they both ran away and never came back to the OPD. So these are all other issues. How to deal with these patients is a problem. In fact, one of the NGOs had analyzed why there are problems or why we cannot help as many women as we could have, because often the medical examination overemphasizes presence of injuries. Sometimes they're too scared to actually protest. History taking has to be meticulous, and 80% of the cases can be sorted if you have proper documentation, because by the time the court wheels move, it is often a few years or sometimes even 8 to 10 years beyond the actual act. Police requisition is not required for examination, please remember. And sometimes doctors are afraid of appearing in court. And in fact, sometimes my residents tell me, मैडम आज बहुत बिजी था, 4 assault आए थे, हमारा 3-4 घंटा उसमें गया. When they are making excuses of why they were not able to handle other work. So this is something we have to give priority to all these aspects, and we have to be updated with current situation and law. Despite doing all this, we have also had to face brickbats. Sometimes when there's a PPH happening, maternal death is the thing you're worried about. Sometimes you may have to make the survivor wait. And this in fact came in the newspaper. But these are the challenges we face as practitioners. Yes, practice is becoming more defensive, but keep meticulous records, communication, and documentation. We have had people coming with, and the question is that the child who is 16 does not want to be examined. The guardians want her to be examined. Here, you cannot force the examination. So there is something known as an assent form also, which you have to fill. So our bodies like FOXI, IMA, AMC, MOGS need to have guidelines for practice to make the lawyer go away. But it's not so easy in POXO cases because there are many, many issues. Henry Ford had said, quality means doing it right when no one is looking. So we have to be very particular about our protocols, be up to date day to day, so that we can give priority to women's health and ensure that this conundrum between the laws, sexual assault, confidentiality of the patient does not compromise the healthcare we are giving. There are many, many dilemmas within the various acts. A lot of people call me and ask me that, oh, she is now 24.6 weeks. What do we do? There is no solution other than a medical board examination. The other thing which all of you are aware of is that now up to 20 weeks, opinion of one practitioner is enough. But for 20 to 24 weeks, we require opinion of 2 practitioners. So these are small, important changes which are helping us to deliver healthcare well. Yes, I'm sorry if I've rushed through the slides, but I have finished just in time. So I will hand it back to the chairpersons in order for proceeding with the session. Thank you very much for the invitation. Thanks to Dr. Sampath Kumari and ICOG team.
Thank you, Dr. Reena Mani. That was an excellent presentation, and you brought out various kinds of clinical scenarios that we face day in and day out, and especially with the changing norms, not only the assault, but the consensual sexual activities also increase. So I think we as doctors need to be very aware of these because we are going to encounter them more and more in our practice. Thank you for the lovely talk.
Thank you very much. And I'll be happy to answer questions in the chat box, if any. And of course, you all can share the recording with everyone. So in fact, the medical board details are there on the website of the government also. People are asking about that. But there is only one board per state. So in Maharashtra, and at least in Mumbai, our medical board is at JJ Hospital, and we need to refer over there if required.
Thank you. Thank you so much, Reena. That was really wonderful. And really, like you said, these are such huge topics that they deserve 1.5 hours dedicated lectures and to complete them in such a short time. But you did a great job. So we now proceed with the next session for today. And again, I'll now request Meena ma'am. I'm so glad she could be unmuted. I'll request her to introduce the next speaker for the day. Dr. Asha Bakshi. Madam, will you please do the honors?
Yeah, it indeed is a pleasure to introduce Dr. Asha Bakshi, Madam. She is the Vice President 22 West Zone FOXI, and she has held so many organizational positions in various societies. And she was also the chairperson of the FOXI Infertility Committee 7 to 19. And Madam, with a great organizer, a great person, very charming lady. We all love to hear you talk, ma'am. Over to you.
Thank you, Meena ma'am. And Asha ma'am. Asha ma'am. Has Asha ma'am joined ICOG team?
And see her.
Okay, I'll just make a quick phone call.
In the meantime, I would like to thank Dr. Supriya and Dr. Sampath for the kind invite to this wonderful session, for making us a part of this session, 3-day session.
Asha madam is not answering the phone. Sampath ma'am, I think we will proceed with the next session in that case.
Yes, Lakshmi madam is there.
Lakshmi
No, we'll start
ma'am
with
is
her.
there. So, Meena ma'am, we'll keep you on hold till Asha ma'am joins. And meanwhile, I'll invite the other 2 chairpersons for the next session. And as soon as Asha madam joins in, we will bring in her lecture.
Sure.
Now
So,
I am unmuted. Yeah.
let me introduce and invite the chairpersons for the next session. A warm welcome to Dr. Anita Sabharwal, Foxy champion, Wonder Foxian, Foxy superstar. What a lovely, title. Recipient of the Foxy Dhira Award and a Foxy Achiever Award. President of the Forum of OBGYN, North Zone Coordinator of PAC Foxy, Chairperson Public Awareness Committee of ISCC 2019-21, and past Chairperson Adolescent Health Committee AOGD. Awarded the gold medal. Madam, it's indeed a pleasure to have you on board. Welcome. And Dr. Das, I think, has not been able to join for some reason. So I'll invite the next chairperson, Dr. Kavita Singh, Professor and Head of OBGYN and NSCB Medical College, Jabalpur, MP, IACA Fellow Gynecology Oncology at Roosevelt Park Cancer Institute, Buffalo, New York, and a great teaching experience of more than 20 years. She's been the National Academic and Services Awarded, received, that is Usha Saraiya Madam's Award for Foxy ICOG Guest Lecture, Best Community Service and Rotary Award, and several such awards. Dr. Kamini Rao and PC Daruwala Oration Award, such prestigious awards under her belt. Welcome, Madam. And I'll now request Anita Sabharwal ma'am to introduce the first speaker, Dr. Lakshmi Srikande. Welcome, Lakshmi ma'am. And Dr. Sabharwal, will you please do the honors? Anita ma'am has joined, right? Is she unable to unmute herself? Team, please check. Dr. Kavita ma'am, are you there?
We will introduce Supriya.
Sorry?
Why unnecessarily waste time? We can introduce
Anita madam is there, but madam, they are all there, but they are unable to unmute. ICOG team, can you please unmute Anita Sabharwal ma'am?
ICOG team is Lakshmi madam.
Sampath, I am admiring you. Year after year, you are conducting this Foxy ICOG course on adolescent health, and every time you are coming out with a wonderful module.
Yes, madam.
Say every time you choose to give me the difficult topics.
You can do it now, madam.
Anita ma'am, have you been unmuted? Kavita and Anita ma'am, ICOG team, please do the needful.
See, they are waiting to introduce Lakshmi madam, such a great person.
Yes, see, madam.
Anita, Are, please allow her to unmute. Anita Sabharwal is here.
ICOG team is resting and having tea, I think.
Yes.
Yes, Anita ma'am.
Yes,
Anita. Good evening, everyone. It's so heartening to see all of you here. And it's an honor to introduce Dr. Lakshmi Srikande ma'am, one of my favorite seniors, I would say. And she's been the immediate past chairperson, Indian College of Obstetrics and Gynae, ICOG, the most prestigious one. And she's such a great orator. It's a treat to always listen to her. She's a national corresponding editor, Journal of OB-GYN of India, JOGI, the very famous one, and also National Corresponding Secretary, Association of Medical Women of India. So she is a woman of substance, and so many awards to her credit. And I think she is one person who's doing so much for the women of her country. And she is not only popular in her own state, but in our own country and also all over the nation and world, I will say that. So let's hear from her what she has to update us about. So Lakshmi ma'am, please go on. Let's hear from you.
Thank you so much, dear Anita, for such a generous introduction. So friends, my topic of discussion today in this course is mental health in adolescent. And as you can see in my intro slide itself, that 1 in 5 teens, they are having a mental health condition, and you all will agree with me that mental health matters. WHO Constitution has already said that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So, mental health, what it is? It includes our emotional, psychological, and social well-being. Children and adolescent, we all know that constitutes 40% of our national population, which is approximately 300 million, which is a huge number. On one hand, we say that adolescent is a phase of tremendous growth. On the other hand, during this transition phase, they are more vulnerable to psychological disorders, adjustment problems, and suicide risk. So positive and promotive mental health in this period ensures a smooth progress to later adult life. Why I am saying so? Because mental health issues in adolescents, they have a future impact in adult life as well, in the form of increased risk of depression, anxiety, and substance use disorders, adverse impact on academic performance, excessive use of gadgets, and gaming disorders. There are 3 types of adolescent psychiatric disorders: neurodevelopmental disorders, which we don't see; emotional disorders, it is in our domain; behavioral disorders, again, psychologists and psychiatrists, they see. Emotional disorders are mainly, first is depression, second is anxiety, and third is stress related disorders. In that, conversion disorder and somatoform disorder, I will tell you in detail, because it really matters to us as OBGYN. Again, don't forget the eating disorders as well. Emotional disorders in milder forms is definitely helpful, but we should know that what are the warning signs when we have to take note of these issues. That if your child is having change in eating patterns, change in sleep, is worried or too much anxious, too much moody, there are drop in grades and decreased interactions with the family. Depression, we all know the major symptoms of low mood, sadness, lots of interest in previously pleasurable activities, easy fatigability. Anxiety disorders, I will not go through this busy slide. We all know if child is too anxious, having panics about the issues, then child is having anxiety disorders. The third disorder, that is conversion disorder. This refers to a clinical condition in which the adolescent presents with loss of function or altered function or dysfunction of one or more bodily parts with no explainable medical cause. So this is common condition in India, and most common symptoms in this form is pseudo-seizures, fainting spells, that is attacks of unresponsiveness, and abnormal movements, that is shaking of the limbs and hyperventilation. Fourth emotional disorder is somatoform disorder. These disorders are characterized by recurrent physical symptoms, that is gastrointestinal, pain-related things, and neurological, that cannot be explained by a medical condition. The most common somatic symptoms are headaches, recurrent abdominal pain, and musculoskeletal pain. Remember, they are not intentionally produced by the child. Eating disorders, of course, we all know anorexia nervosa and bulimia nervosa. Now coming to some of the common issues associated with this age group. First is self-injury and suicidal behavior. Remember, self-injury is deliberate destruction or alteration of body tissue without the intent of committing suicide. And self-cutting is the most common method of self-injury. There are consequences of this self-injury, long-term consequences, medical consequences, and of course, this behavior has impact on parenting as well. When it comes to medical consequences, yes, we are concerned because there is increased risk of blood-borne disease transmission in adolescents who attempt self-cutting, especially with shared use of sharp objects. Second is suicidal behavior. Remember, here there is an intent of dying, and that is why it is a suicidal behavior. Among adolescents, the risk of suicide is about 1.3%. The risk factors for suicidal behavior can be biological, psychological, and social. Biological, if there is a family history of suicide, parents are having history of depression. Psychological, it is poor emotional regulation. If the child is perfectionist, if the child is having low self-esteem. And social, yes, academic difficulties, family conflict, and bullying. But there are certain protective factors also against the suicide behavior. That is, if they have a positive family environment, good social support, good problem solving skills, they have access to mental health care. Now, another major issue in this age group is substance abuse in this age group. And globally, 25 to 90% of children, they have ever used at least one substance of abuse. So what are the red flags which warrant a treatment in these cases? There is drunken driving, using alcohol with other drugs, using IV drugs. If they are engaging in unplanned or unprotected sexual activity under the influence of drugs, there is sudden change in behavior and the grades in the school are decreasing. This is the intervention, that is frames, that again has to be taken care by the psychologist. Now coming to the impact of social media on adolescent mental health. In this slide, just Instagram is mentioned, that 4 in 1 Instagram users are under 23 years old. And this is the various list of social medias of which I was also not aware that we are having so many social media platforms. And this emergence of social media platforms has indelibly altered the landscape within which adolescents they navigate these critical transitions. And adolescents they increasingly find it difficult to picture their lives without the social media. When we are talking of social media, the first and foremost thing which comes to our mind is cyberbullying. Remember, the emotional consequences of cyberbullying are profound and far-reaching. The victims, they often experience heightened levels of stress, anxiety, and depression. And the management has to be a multifaceted. Any victim who is going through cyberbullying, they can do online complaint, which is a very, very easy process. Now, another issue related to social media addiction is body image, because this social media has significantly influenced the body image perception among the adolescents, because most of the times the unrealistic body standards are projected. Adolescents are bombarded with pictures of perfectly sculpted bodies, flawless skin, and curated appearance that propagate a narrow definition of beauty. So the adolescents who they are at higher risk of developing body dimorphic tendencies, low self-esteem, symptoms of depression and anxiety. The third issue here is FOMO, that is fear of missing out, which contributes significantly to feelings of inadequacy and anxiety. And this FOMO is driven by the incessant updates and posts on social media platforms that showcase their peer activities, experiences, and social interaction. So they have a constant fear of being excluded from the events and moments that other persons are enjoying. And this feeling can evoke loneliness, inadequacy, and sadness in the adolescents. So the addiction, social media addiction, has sparked concerns about its impact on adolescent mental health. And the allure, why they are so addictive, it lies in the instantaneous gratification it offers through notifications, likes, and comments. And this constant feedback triggers the dopamine response in the brain, creating a reward loop that fosters the addictive behaviors. Remember, this addiction can lead to a neglect of real world relationships. It hinders their academic performance and exacerbates the feeling of social isolation. So we have to teach them the healthy use of this digital technology. But how? See the use of mobile phones by the adolescent age group. In India, 95% of Indian children, they live in a household with mobile phones, and at least 76% of children in the age group of 7 to 11 years, they have access to mobile phone of their own. These are the various physical and emotional health risks associated with excessive use of the mobile phones. But remember, digital technology has got positive impacts as well. We are always talking about the negative impact. This social media is a tool for communication with family, friends, and this improves the social connection. Many educational apps and videos are there. It is used as a medium to supervise the child's whereabouts. Digital space offers a sense of belonging where individuals can share their experiences, fears, and times without fear of judgment, and it is a powerful platform for mental health awareness campaigns. So all said about the disorders which our adolescents are facing, how we should assess. Remember, the assessment of emotional disorder has to be done for the child, for the family, social environment, and of course you have to rule out any medical illness. For the assessment of child, you have to have a questionnaire, you have to ask about the child's feelings. As far as family history is concerned, yes, you have to ask about the socioeconomic status, then the family dysfunction, marital discord, parent-child conflict should be inquired. Remember, you have to do the assessment of the child's environment as well, that what are the academic expectations from this child, because the academic setbacks and upcoming exams also create a lot of emotional problems in the child. Then you have to rule out medical problems like thyroid diseases, nutritional disorders, chronic medical conditions, and malnutrition. Management is usually by the psychologist. It should be done early and thoroughly. And for moderate to severe, you have to give the pharmacological treatment, or for that, SSRIs are safe to use in children above the age of 12 years. For conversion and somatoform disorder, when this child or adolescent comes to us, we have to educate the family that this child is having real symptom and sufferings, but the reasons could be psychological and not physical. And as a clinician, we have to reassure the parents and the caregivers. Now, there are various barriers in the service delivery. First is the stigma about the mental health, lack of education and awareness, and in India, only 1/3 of the families with mental disorder, they perceive that their children actually is having any psychiatric problem. So what is the role of parents in the mental health? Positive parenting and a supportive family environment will definitely have a positive impact of mental health. Second role is the role of schools, because after home, the schools are the best place to promote mental health. Teachers can serve as gatekeepers to mental health issues. We have to sensitize and train the teachers and the counselors who are there in the school. The management of academic difficulties in school should be taken care by the teachers, and of course, adolescent health education programs, including the sex education, should be imparted regularly in the schools. Bullying, school bullying is very common in many schools throughout the world, and this bullied child, they suffer from depression and anxiety. So all schools should be encouraged to have a zero tolerance policy towards bullying. And when we are talking of bullying, it can be a physical bullying, it can be a verbal bullying, or it can be a cyber bullying. Now, another very, very important aspect to teach to the adolescent is life skills training. What is it? WHO defines life skills as adaptive and positive behavior that enables individuals to deal effectively with the demands and challenges of everyday life. And these life skills include social skills, cognitive skills, and emotional skills. Social skills, you have to teach child effective communication, interpersonal relationship, empathy, self-awareness. In cognitive skills, you have to teach the child about problem solving, decision making, creative thinking, critical thinking. And emotional skills, you have to teach the child how to cope with the stress and cope with his or her emotions. So for whom life skills? For all children. By whom? You cannot say that it is not my job because I am a clinician. By life skills can be imparted by doctors, teachers, counselors, everyone.
Ma'am, your time is up, ma'am.
Yeah. I'm just concluding. So we also have a role as OBGYN because we are coming in contact with the adolescent age group girls. We have to inquire about the mental illness in them. Our national health policies are very, very good because now they are giving more and more importance to the adolescent mental health apart from the nutrition and anemia. So the key takeaways from my presentation is we know that mental health issues are on the rise. They have a long-term impact on the future life of this child as an adult. Parents and teachers, they play, but we OBGYNs can also play a significant role as we get opportunity to identify and address the mental health concerns. We can encourage open communication and provide a non-judgmental space for adolescents to discuss mental health issue, and we have to understand and address the unique challenges faced by the adolescent girls. And of course, don't forget to impart the life skill training to each and every adolescent who comes in our contact. Thank you. Thank you so much for your patient hearing.
Thank you, ma'am. Thank you, Dr. Lakshmi, ma'am. It was a wonderful lecture, really informative, updating, very interesting, and very meaningful. I think this is a need of the hour because our future generation, our future of a country, they really need lot of support, as you said. And it has to start from the family, and then it has to go to the teachers, and then us. So we all together, we can really do wonders for them. And I feel, because I am at the very awareness level, as you know, so we have to really create lot of awareness amongst everybody, amongst each family, in fact. So if each family is aware, they can be of help to the neighbors, to the resident welfare associations, and ultimately the whole country and the whole nation. So awareness is the key to any preventive program. And see, like I go for my daily morning walk, I always tell everybody, we have to follow the 6 natural doctors. If all these things happens in the family, right in the beginning, the children are going with their parents even when they are adolescents, so they understand the value. Because we just say 6 doctors, they don't get to know the depth meaning, like what we are getting there. We are getting fresh air, we are getting the sunshine, we are getting the exercise when we are going for walk. And for going from an early morning walk, we have to sleep well in the early at night. So the way we used to say, go to early to bed and early to rise makes a man healthy, wealthy, and wise. We know all these things, but we don't actually practically follow them. So all this, then we talk about nutrition, then we talk about water. So all these 6 natural doctors, if we are just following everybody, I think most of these problems could be solved. So awareness and prevention, they can do wonders. And thank you so much for giving us so many disorders and all, otherwise we'll be not knowing them. Thank you so much, ma'am. Dr. Lakshmi.
You can talk like this, mental health, rather than Lakshmi madam, no? That's the way the topic is going to work.
Sampath ma'am, I'm just coming to meet you soon.
Yes,
Thank you, ma'am. Thank you so much. We now proceed to the next scientific session. If Asha ma'am does not join, then this is
Asha will join after 5 minutes. She is in another webinar. You introduce Dr. Sarita.
Okay, then we'll proceed meanwhile with the next session. So since Meena madam is still here with us and Kavita ma'am could not join in, Meena ma'am, I'll request you to please, introduce the next speaker, Dr. Sarita Shamsundar. ICOG team, can you please display Sarita ma'am's CV? Madam will
Yes,
be
ma'am,
speaking
yes.
on ovarian neoplasia in adolescent. And I'll request Meena ma'am to please introduce the speaker.
So, Dr. Sarita Shamsundar is a very well-known personality in oncology. And may I have a CV? Yeah, she's working in New Delhi. And we've been constantly listening to her, seeing her in workshops and CMEs. We know she's also headed one of the organizations in oncology, that is AOGD. So, ma'am, I'm not getting a CV, so I'm just saying what's coming to
Meena,
my
it is
mind.
displayed. See
Ma'am, it is displayed. It is
Meena,
displayed.
it is in the screen.
How come yeah, now I can see. So she's the professor and the head of the gynae oncology at Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi, and a board member, International Federation of Colposcopy and Cervical Pathology, and organized Asia's first IFCPC World Congress of Colposcopy and Cervical Pathology in the year 2021. And we in Patna also have a chance, to be to one of her colposcopy lectures. She's a chairperson of the Oncology Committee, AOGD, and immediate past president of Society of Colposcopy and Cervical Pathology, member of the Technical Expert Group of Cervical Cancer Screening Program of Government of MP and Punjab, Master Trainer, MP State Government Cervical Screening Programs. She's also, in a publication author, 2 books, many chapters and articles in national and international journals. So over to you, Dr. Sada.
Thank you so much,
Yeah.
Dr. Meena, for the kind introduction. And thank you, ICOG, for this invitation. I will just go to my presentation. Can you see my slides?
Yes, Sarita.
So they have.
Yes, ma'am. Yes, ma'am.
Yeah. So talking about ovarian tumors in adolescents.
No, slides.
Yeah. Can you see?
Yeah, you can proceed.
Yes, ma'am, it's perfectly visible. Yes, ma'am, it's visible.
Yeah, okay. So if you look at malignancies in adolescents, they can be gynecological or non-gynecological. Of the commonest are the gynecological or the ovarian tumors. The malignant, the gynae malignancies actually constitute 4.2% of all malignancies in girls less than 18 years. This is according to the SEER database. And the gynae malignancies, of them, ovarian tumors are the commonest. And the type of ovarian tumor, the germ cell tumors, are the commonest in adolescents. So how to work up if you find an adnexal mass in an adolescent? What could be the other causes? So if you find an adnexal mass, commonest, of course, is ovarian. The ovarian can be, or it could be extra ovarian. So the ovarian masses can be functional cysts, it could be endometriosis, it could be germ cell tumors or epithelial tumors, benign or malignant. The extra ovarian masses also they can present as an adnexal mass, like ectopic pregnancy if she is sexually active, inflammatory masses, especially tubercular adnexal mass, a para-ovarian cyst, or a broad ligament fibroid. So all these should be considered in the differential diagnosis of an adnexal mass in an adolescent girl. So what is the origin of the ovarian tumors? So the ovary, if you look at the structure of the ovary, you have the germ cells here. And then you also have the follicle, which is lined by the granulosa and the theca cells, and then you have the stroma, which has the fibrous tissue, and then you have the surface epithelium. So from the surface epithelium, you can have all the serous, mucinous, endometrioid, clear cell, and transitional cell tumors. From the germ cells, you can have dysgerminoma, yolk sac, embryonal carcinoma, choriocarcinoma, or teratoma. From the sex cord stromal tumors, you can have granulosa cell tumors, theca cell tumors, fibromas, Sertoli cell, Sertoli Leydig cell tumors, and steroid cell
tumors. So the primitive, what are the types of ovarian germ cell tumors? So they could be coming from the primitive germ cell, when it could be a dysgerminoma, it could be a yolk sac tumor, embryonal carcinoma, polyembryoma, non-gestational choriocarcinoma, or a mixed germ cell tumor, or it could be biphasic or triphasic teratoma, that is the immature or mature teratoma, or it could be monodermal teratoma, that is, it is differentiating on only one type of cell. So that is the thyroid tumor, that is the struma ovarii, and it could be either benign or malignant, or it could be, it could transform into carcinoid, or it could transform into neuroectodermal tumor, carcinoma, melanocytic tumor, or sarcoma. So it can differentiate into any type of tissue. So how to approach the adnexal cell mass in adolescent and young adults? So it's whenever you find a case with an adnexal cell mass, all these symptoms are important to ask for. Any history of fever, because it could be a tubercular mass, if you, for all you know. So it is any history of fever, weight loss, cough, abdominal pain, dysmenorrhea, any family history of tuberculosis or malignancy, any vaginal bleeding or premature menarche, because this will point to a sex cord, a functioning sex cord stromal tumor, any history of heavy cycles. Again, that would mean a functioning ovarian tumor, any history of breast atrophy or excessive hair growth, change of voice, clitoromegaly. So this will mean that it's probably we are dealing with masculinizing ovarian tumor like Sertoli Leydig cell tumor, and any urinary symptoms because of pressure that could lead to urinary symptoms. So examination, again, one should look for lymphadenopathy, because you can find generalized lymphadenopathy in tuberculosis and lymphoma. Sometimes, rarely, lymphoma can present as an adnexal cell mass. Hirsutism, look for hirsutism, premature thelarchy, clitoromegaly. All this indicates a sex cord stromal tumor. Pleural effusion and ascites can indicate a tuberculosis or malignant ascites. And hepatosplenomegaly, it could be probably because of leukemia. So what to do, how to investigate a patient with an adnexal cell mass? So these things are basic, CBC and an ESR, a chest X-ray, Monto. This is mainly to rule out tuberculosis. Ultrasound is the first investigation, and tumor markers. So let us see what are the tumor markers we need to do. So the tumor markers, so the various tumor markers in this age group, in adolescent age group, we need to do is alpha-fetoprotein, HCG, LDH, placental alkaline phosphatase, CA125. Because why CA125? Because this adnexal cell mass could very well be an endometriosis. So if it's a raised CA125, it could suggest that the mass could be endometriosis. So the premenarchal age group, and the mass is more than 2 centimeters and with positive tumor markers. So a karyotype is indicated, because it could be an XY karyotype we are dealing with. And then surgery, followed by surgery if you find a mass and an XY karyotype. So if it's a cystic mass and the tumor markers are negative, the size is less than 8 centimeters, negative tumor markers, then it could just be a functional cyst. So hormonal suppression for 2 months is advised. And if the size is decreasing, then just put her on follow-up. Whereas if she's a post-menarchal patient and the cyst is more than 8 centimeters and you find solid areas or suspicious with positive tumor markers, then definitely she goes for surgery. So the tumor markers, we know all these types of tumor markers. So CA125 is a very non-specific tumor marker. It could be, you can find epithelial tumors in adolescent age group, which could be serous or mucinous. But the cancers are rare. More commonly, we find benign ovarian tumors in this age group. HE4, this is increased in epithelial ovarian cancer, but it's not raised in benign conditions like endometriosis. So if it is not raised, if you do HE4 and it's not raised, it's probably suggests endometriosis. And then we have the CA1, CEA. These are not these are not required in this age group, but rarely, very rarely, you may find, it could be a deposit from somewhere else. It could be a Krukenberg tumor, but that can be very rarely found. And then the commonest tumor markers that we need to do are the LDH, alpha-fetoprotein, and beta-HCG, because these are raised in the germ cell tumors. So the primordial germ cell tumor, as I said, so from the primordial germ cell, you can have germinoma or you can have embryonal carcinoma. From the germinoma, it develops a dysgerminoma, which will have negative alpha-fetoprotein and negative beta-HCG. From the embryonal carcinoma, you will have, the embryonal carcinoma will have alpha-fetoprotein positive and beta-HCG also will be positive. Now, if that is developing as an extra embryonic differentiation and it forms the trophoblast, then that forms a choriocarcinoma in which you find HCG will be positive. Whereas if it develops as a yolk sac tumor, so then that is the endodermal sinus tumor. Here the alpha fetoprotein will be positive and HCG will be negative. Whereas if it's developing from the embryo, it has formed the embryo and then it has developed from the embryo, then it becomes it forms the immature teratoma where both alpha fetoprotein and beta HCG are negative. So just by doing these tumor markers, we can know what is the type of tumor that we are dealing with. Now, what about the ultrasound? So ultrasound, how does ultrasound help in the diagnosis? So we know these simple rules. A simple cyst is a very thin wall with anechoic fluid with no septations, and complex cyst has complex septa and solid nodules and papillary projections. And you have the iota simple rules, with its benign or malignant. And this is what the benign, the B rule is when you find a unilocular cyst and you find solid components, but it is less than 7 millimeter in diameter, and there are acoustic shadows and the smooth multilocular tumor, and the size is less than 10 centimeters. Any smooth tumor which is less than 10 centimeter in size is a benign tumor, and there is no blood flow. But if you find an irregular solid tumor with ascites, with at least 4 papillary structures, and it's a multilocular solid tumor and the diameter is more than 10 centimeters, and there is a very strong blood flow, that means it could be that we are probably dealing with a malignant ovarian tumor. So this is what the other pictures. So these are the simple rules where you find that there's a unilocular cyst, and this is there is a solid area, but it's very small, very tiny, less than 7 millimeters. And then here you have acoustic shadows. So this typically indicates that there is calcification in a dermoid. And then you have these multiloculated tumor with thin septa, and then there is no blood flow. All these indicate the benign features. And then what indicates malignancy is when there is irregular solid tumor, there is ascites, then there are at least 4 papillary structures, and then it's a multilocular solid tumor, solid cystic, and its size is more than 10 centimeters, and there is very strong blood flow. All these are indicative of malignancy. So then if all these features are present, more than one benign feature means it is benign. If there is more than one malignant feature, no benign feature, that means it is malignant. And if there are both benign and malignant features, then we go to step 3, that is you have to take the opinion of an experienced radiologist, and that is the 3-step strategy, and that works best for making a provisional diagnosis. And then recently we have the ORADS reporting system in 2020 by the American College of Radiology, based on years of data established by IOTA and other studies. So what does the ORADS say? What are the categories? So we have the ORADS. So you give the radiologist gives a score based on the findings you get on the ultrasound. So anything ORADS 0, 1, and 2 means it is benign. So if it's a simple cyst, a classic benign lesions, all this gets a score of between 1 to 2. And if it's a low, ORADS 3 means it's a low risk of malignancy, where you have a unilocular cyst, a typical dermoid cyst, endometrioma, a unilocular cyst of any size, multilocular cyst of less than 10 centimeters with a smooth inner wall, or a solid smooth tumor. All that indicates a low risk of malignancy. And ORADS 4 means the risk is intermediate. There's an intermediate risk of malignancy. The risk of malignancy is between 10 to 50%. That is. So it's classified as intermediate when it's a multilocular cyst with no solid component, unilocular cyst with a solid component, but it's a small solid component. And if it's a multilocular cyst with a small solid component, and it's a solid of any size. Whereas high risk, again, if there is more than 4 papillary projections, a multiloculus, it's a solid cystic tumor, and the ascites, peritoneal nodules, all this indicates that is high possibility of malignancy. Now, what is the role of MRI and CT when ultrasound and cannot conclusively predict the type of mass? That's when the other additional imaging is indicated. MRI gives a better morphology. CT should be done only when the mass is suggestive of malignancy. Ultrasound is suggestive of malignancy for staging, and CT should be avoided in this age group because to avoid radiation. And PET CT is not indicated because it is not informative. The advantages of MRI, it can tell you about the contralateral cyst, it can tell you about any lymph node involvement, and it can tell you whether the mass is engulfing the ureter, and if it's a endometriotic cyst, if it's a deep pelvic endometriosis, that can be indicated on the MRI. Now, what are the principles of surgery in adolescent ovarian tumors? So the surgical approach should be carefully selected on the basis of initial imaging. You should avoid intraperitoneal rupture. So oophorectomy is preferred to cystectomy or tumorectomy, and biopsy of the tumor is absolutely contraindicated. And midline laparotomy is the preferred option. When you suspect a malignant tumor during pre-op staging, and minimally invasive only if the surgeon is trained in laparoscopic surgery. And the removal of the tumor can be performed without rupture, and no morcellation of the specimen occurs during removal, and full exploration of the peritoneal cavity should be done. And before you manipulating the tumor, the peritoneal fluid should be sent. And if there's no fluid in the abdominal cavity, the peritoneal washings should be performed. And in case of bilateral tumors, bilateral salpingoophorectomy is strongly discouraged, and preservation of at least one ovary should be promoted. So staging includes, the standard surgical approach, explore all the peritoneal surfaces, subdiaphragmatic areas, paracolli gutters, pelvic peritoneum, and examination and palpation of the pelvic and paraortic areas, sampling of any enlarged lymph nodes. So it should be, or if they are enlarged, there should be just sample. Just a complete lymphadenectomy is not necessary. Inspection and palpation of the omentum and removal of adherent or abnormal omentum. Inspection, you must always inspect the contralateral ovary, and if there is an abnormal appearing area, that should be biopsy. And fertility sparing surgery is to be done, saving the uterus and at least a part of one next. If the other ovary does not appear to be normal, so at least a part of the ovary should be saved. So that is the first surgical option. When there is macroscopic extra-ovarian disease, then there's biopsies of all these extra-ovarian disease should be performed. And oncofertility counseling should be offered to all adolescents even before the surgery and even before chemotherapy. And the tumors, because they need to be classified as per the 2014 WHO classification, and you need an experienced pathologist to report on this. And so many times I had seen.
Sorry to interrupt, ma'am,
yeah.
but your time is up, ma'am.
Yeah, I'll just finish. So in early stages, maybe genetic analysis should be performed when there is to detect any sex chromosomal aberrations, that is an XY karyotype, especially in a dysgerminoma. And if initial cystectomy has been done on the basis of the final, and if you find that the tumor markers are normal, additional surgery to remove the residual ovary is required. So if you find that later on after cystectomy, you find that it's a malignant germ cell tumor, then residual tumor should be taken out. For dysgerminoma and mature teratoma, there is a risk of bilateral involvement, and postoperative ultrasound monitoring of both ovaries is recommended. And if its tumor is likely to be malignant, laparotomy is appropriate for removal of the tumor for staging and to minimize the risk of intraperitoneal spillage. So reoperation for when the diagnosis is made, suppose if you do a salpingoophorectomy and later on you find that it is malignant, then it's not reoperation is not indicated for lymphadenectomy and surgical staging. Nodal removal only when there is evidence of nodal abnormalities, and in completely resected stage 1A and with normal tumor markers, active surveillance is the preferred approach. And in stage 1A, yolk sac in non-compliant patients, so adjuvant therapy is an optional management. So when there is XY karyotype, both ovaries should be removed. If there's a dysgerminoma, and uterus should be left for future embryo transfer. In advanced stage, it's mainly they go for chemotherapy. So as much as possible, the disease should be removed, and as far as possible, the part of the ovary should be left if it appears to be normal. And the standard chemotherapy is the PEP regime. So this is about the dysgeminoma. If it's just confined to one ovary, unilateral salpingoophorectomy, inspect the contralateral ovary and surgical staging. If you don't find any metastatic disease, then just surgical surveillance. But if you find metastatic disease, then BEP is given. And if there's a small focus in the contralateral ovary, resect that focus with ovarian preservation followed by chemotherapy. If there is metastatic disease, then unilateral salpingoophorectomy and remove the readily resectable metastasis followed by BEP. So I'm not, this is just a summary. Basically, if we find a malignant germ cell tumor and we know that in this group fertility is desired, so fertility sparing surgery should be done. And if it's completely staged and it's just a dysgeminoma, a grade 1 immature teratoma, and if everything is negative, then they can be kept on follow-up. But if you find positive imaging, positive tumor markers, then fertility sparing surgery. So if she has been incompletely staged earlier, then fertility sparing surgery and comprehensive staging should be done. But if new tumor markers are negative, then consider observation only. But if it's embryonal carcinoma, endodermal sinus tumor, grade 2-3 immature teratoma, non-gestational choriocarcinoma, if you find positive imaging, positive tumor markers, and fertility is desired, then fertility sparing surgery and comprehensive staging should be done. If fertility is not, then we know that fertility is desired. So this is the path we should be following. But if they're negative imaging and positive or negative tumor markers, they go for chemotherapy. So I will just skip this. So I don't know, we don't have time for the case. So it's okay. So this was an 18-year-old. We actually came out to be, initial imaging showed a complex ovarian tumor suggestive of immature teratoma, but per off we find that she has bilateral. So we sent one for did a salpingoophorectomy, sent for frozen section, and the other side we did a cystectomy. So the frozen section, luckily it was a dermoid cyst. So we can have these surprises. So the proper counseling is needed. So we must remember that fertility sparing, we must think of fertility sparing, because if they need to go for chemotherapy, then oocyte or preservation is important, or ovarian tissue cryopreservation, if facilities are available. Then as far as possible, we should try to preserve one ovary. So take-home message is history and examination is vital to establish a diagnosis. Ultrasound is essential for making a diagnosis, and tumor markers in selected cases, and MRI when ultrasound is inconclusive. So ovarian tumors are the commonest gynae malignancies in adolescents. Of them, germ cell tumors are the most common. The diagnosis, to make a diagnosis, tumor markers, ultrasound, and MRI are helpful. CT should be avoided in young patients, and PET has no benefit. So thank you all for your patient hearing, and seek your support for Chairperson Foxy Gynae Oncology Committee. The elections are upcoming shortly. Thank you so much, Mansali.
Charita, in the chat box, there are some questions. Please answer.
Okay. Okay.
Thank you. Thank you. Wonderful talk.
Thank you.
Asha has joined, I think. Anita or Meena can introduce.
Yeah, it was a wonderful talk, Dr. Sarita. Yeah, and yes, fortunately, the malignancy is rare and far between in teenage girls. However, we have, and also that it's an early stage, and in most of the cases we can conserve. But what to do, when to do, you know, in a very comprehensive way, you've highlighted. Thank you for that. And I think they're ready with the next, yeah. Wonderful talk. Enjoyed it.
Thank you. Thank you. Thank you.
Anita, you can introduce Asha Bakshi.
Okay.
CV is there.
Dr. Supriya, we can't hear you. You are muted.
Dr. Anita, please introduce Dr. Asha Bakshi.
Okay.
Same thing.
Anita, very short introduction. Huh?
Oh, sure.
How can you
I'm
introduce a
very
short introduction for Asha?
honored to introduce Dr. Asha Bakshi. It's really an honor to introduce you. And over the time, you become such a great friend of mine, though you have been the vice president of Foxy, you know. And you are a great, I think you are an all-rounder in academics as well as otherwise. So everything, so many, I think, posts you have to your credit and so many awards, so many papers, whatnot. So I think now everybody's very, very much anxious to listen, waiting to listen to you. So let's hear from you, Dr. Asha Bakshi from Madhya Pradesh, the Hara Bhara Desh. Yeah.
So thank you very much, Anita, for introducing me. And I'm very glad that my talk is after Sarita, because she spoke about the malignancies, and now I can talk about fertility preservation in adolescents. So I think this has fallen really nicely. And Sarita, your talk was very good, and my best wishes to you for your upcoming elections. And
Dr. Asha, I'm sitting here to even celebrate World IVF Day today. I'm here in Delhi in Rose for the World IVF Day. Since you're talking about it.
Yeah. So it's enjoy that celebration, and we have been celebrating through webinar and in our hospital. So a very happy World IVF Day and Embryology Day to all of you. And I'll start with fertility preservation in adolescents, which is really a neglected topic. So, and we have people like Dr. Sarita and all such good oncology nowadays. Good oncology treatments are available. That children and adolescents who have been diagnosed with cancers are surviving, and with that comes in the future the problem of fertility. So it's very, very important that there is an awareness regarding fertility preservation amongst not only the gynecologists but amongst all healthcare professionals, because then only it will be helpful. And because nowadays, and I'm able to talk this because these days we have good facilities of cryopreservation, and that way we can offer fertility preservation to all our youngsters. So what are the indications? Indications can be oncological and non-oncological. And oncological causes are 80% of cancers in adolescents are curable. Chemotherapy and radiotherapy, we all know, leads to temporary, long-term and permanent gonadal toxicity, which leads to fertility impairment in future. And especially alkylating agents are highly gonadotoxic in both males as well as females, and there can be low toxicity, medium toxicity, or high toxicity. But overall, there is threefold rise in chances of premature ovarian failure who have received alkylating agents. And ovarian radiation also can cause 50% follicle depletion at the dose of 2 gray, 60% at the dose of 2.5 to 5 gray. Overall, there is significant decline in AMH level. So it's a very good practice to do AMH levels before fertility preservation in these cases. And there are certain algorithms. And if the AMH levels are very good to begin with, and the chemotherapies of not so much of gonadal toxicity, then these patients tend to regain their fertility in future. So this is what is recommended. And spermatogenesis is particularly sensitive to chemotherapy and radiotherapy. 25 to 28% of the survivors have oligo or azoospermia after chemotherapy with cyclophosphamide. And especially when at the dose of more than 7,500 mH per square meter, all patients were azoospermic. Radiation again can affect spermatogonia, and doses above 0.1 gray can affect spermatocytes and spermatid. And radiation above 6 gray can lead to permanent infertility. So non-oncogenic causes, there are certain conditions like autoimmune diseases like SLE, Crohn's disease, Behçet's disease. These are all associated with premature ovarian failure. Then hematopoietic stem cell transplantation and other conditions which can cause premature ovarian insufficiency, especially Turner syndrome. Here, initially, a girl may have ovulation for few cycles and then she gets premature ovarian failure, Klinefelter syndrome, fragile egg syndrome, endometriosis, ovarian testicular torsion, benign ovarian tumors, gonadal injury, and transgender population. So all these are the situations where fertility preservation can be offered. And what are the options for fertility preservation? So one is oocyte cryopreservation. So these days, we are very fortunate that most of the IVF centers have this facility of oocyte cryopreservation. And whenever we have to do oocyte cryopreservation, naturally, we need controlled ovarian stimulation and then oocyte retrieval. But for that, we need some time. Means we can't, though these days random start protocols are available, but still at least we need 2 to 3 weeks prior to starting the chemotherapy. So that's what we have to discuss, the timeline. And when we use GnRH antagonist protocol, so that it is quickly, we can stimulate these patients. Sometimes we can obtain immature oocytes at the time of ovarian tissue cryopreservation or at the time of oophorectomy. And immature oocytes can be obtained at the time of ovarian tissue cryopreservation and oophorectomy. Now, whenever we give them chemotherapy or radiotherapy, and then there's some people, they tend to use GnRH agonist. So let's talk about GnRH agonist protection. The clinical efficacy during chemotherapy is controversial and current recommendations regarding its use remain conflicting. A prospective study found GnRH and GnRH in agonist administration during chemotherapy protected ovarian function and preserved fertility in adolescent patients. Well-designed, large, prospective, randomized control trials are required. But I think it is such a simple thing to give GnRH agonist, and I think it is worth trying. Then ovarian tissue cryopreservation, it is also now available in India. Certain centers are doing so, but mostly in the West, it is very much, many people are doing. And I think most important is they have these institutions, big institutions and referral centers where ovarian tissue cryopreservation is there. And in India, we have small centers mushrooming. So we don't have a big institute where we can do ovarian tissue cryopreservation. And most of the times in the West, there is governmental funding, because whenever these patients come to us for who have got malignancy, adolescent, parents are first bothered about their cancer itself. And then when you talk about the logistics, the financial thing, then those constraints, because they have to bear for the cost of the treatment and then the cost of the tissue preservation. So that is a big problem, but still it is coming up, and it is the sole option for fertility preservation in prepubertal children and post-pubertal adolescents who cannot delay the start of chemotherapy. Roughly 50% of the cortex from one ovary is surgically removed, dissected and cryopreserved for future use. The ovarian tissue is cryopreserved by either slow freezing or vitrification. When a patient intends to use to restore ovarian function or fertility, the cryopreserved tissue can be thawed and replaced, and multiple transplantation strategies have been developed. One of those is orthotopic transplantation. The frozen tissue can be replaced either orthotopically or heterotopically. Orthotopic sites include remaining ovary and peritoneal pockets created on the broad ligament. And this provides possibility of spontaneous pregnancy because the fallopian tube and the orthotopic transplant are nearer, because it is in the place where original ovary was. So natural pregnancy is also possible in these cases. Now heterotopic transplantation, and here it can be inserted in subcutaneous tissue, subcutaneous areas of forearm, abdominal wall, chest wall, breast, rectus muscle, and subperitoneal tissue. And this is a less invasive surgery and easier follicular monitoring and oocyte retrieval for IVF, easier monitoring for cancer recurrence and removal of the graft if necessary, and most cost-effective option in case of repetitive transplantations. And many women, they do not want to restore the ovarian function but do not desire pregnancy. These advantages can probably make heterotopic autograft a potentially preferable option.
Now, coming to the male adolescents. So, sperm cryopreservation is the easiest thing and has been practiced since long, and it is easily available everywhere. And even in our center, we have done and we have had pregnancies. We did ICSI for these two couples, and they have had a successful outcome. So, sperm cryopreservation with masturbation is the easiest, most reliable method for fertility preservation for pubertal boys. Penile vibrostimulation, a non-invasive method, can be an alternative when there are difficulties in masturbation. However, when sometimes you cannot, the boy cannot masturbate and it is difficult, then in those cases you can consider electroejaculation and testicular extraction. But these are really invasive, and for that young boy it may be difficult, and we have to think about the harms that it can cause. Then immature testicle cryopreservation. So it is only fertility preservation option for prepubertal boys as spermatogenesis is absent. Small pieces of immature testicular tissue are surgically removed for cryopreservation, but still it is not as developed as ovarian cryopreservation. So clinical outcomes after fertility preservation. So for oocyte cryopreservation in adolescents, it's an effective method, and the clinical outcomes using cryopreserved mature oocytes have been steadily improving. The clinical outcomes between vitrified oocytes and fresh oocytes are similar. The vitrified oocyte ICSI is used instead of whenever you have to do oocyte cryopreservation, you have to remove the cumulus. So you cannot do IVF for these patients. You have to do ICSI for these patients. And fertilization rates with ICSI are around 72 to 80%, and implantation rates are around 40% per embryo transfer, like any other IVF procedure. And we nowadays most of the centers are getting very used to this, because many girls are coming for social egg freezing. So in this practice is getting very popular. So oocyte, but one thing to remember, that the younger the patient, higher is the aneuploid rate if she is younger than 20. Now, clinical outcomes after fertility preservation. Now coming to ovarian tissue cryopreservation, sole option for fertility preservation in prepubertal children and postpubertal adolescents who cannot delay the start of chemotherapy. I think we have already talked about it. So sperm and testicular tissue cryopreservation. Higher success rate is observed in ICSI as compared to IUI and IVF, and longest duration of sperm cryopreservation to date is 28 years, which successfully resulted in a healthy live birth with IUI. What happens is you have few samples, so you can't afford to fail with IUI or IVF. You want to do a procedure which has more success. So naturally, you want to do ICSI in these patients. The documented clinical pregnancy rates using thawed sperm collected before cancer therapy ranges from 18% to 57%. For those patients who had their testicular tissue cryopreserved, the fertility restoration strategy includes autologous grafting from immature testicular tissue and injection of testicular stem cells into the testis, and in vitro maturation of TSG. Now, transgender population, this is a new thing which is coming up. People want to gender affirmation surgery or gender affirmation hormone replacement therapy. And today only in another webinar where I was listening to Dr. Nandita's talk, and they were doing oocyte retrieval for someone who wanted the gender affirming surgery. So considering most transgender persons are reluctant to postpone or suspend gender affirming therapy, it appears even more important to start consultation as early as possible. And especially for trans men, oocyte cryopreservation, embryo preservation, and ovarian tissue cryopreservation are established methods of fertility preservation. Trans men who have not started not started gender affirming hormone therapy, ovarian stimulation protocols are same as those used for any other infertility case. GnRH antagonist protocol can be considered for its efficacy and oocyte yield, and addition of letrozole can reduce estradiol levels and related symptoms, because these patients, they do not want high estradiols because they want ultimately to become men, so they don't want estrogen effects. For pre-puberty trans men and those who are unwilling to accept ovarian stimulation, ovarian tissue cryopreservation is the sole option for fertility preservation. Auto-transplantation of cryopreserved ovarian tissue has resulted in more than 200 live births worldwide. Now, fertility preservation of the trans women. Sperm cryopreservation is a reliable option for fertility preservation amongst trans women. Sperm may be obtained by either masturbation, assisted ejaculation, or TSA. Cryopreserved sperm could be used for IUI, IVF, ICSI, and in the cisgender female partner. For prepubertal transgender girls, testicular tissue cryopreservation remains the only option. So what are the current challenges? The current challenges is there is limited knowledge of clinical practice guidelines and poor compliance with recommendation by medical professionals. Most patients and their parents are dissatisfied with the content of information that healthcare professionals provide concerning the fertility risk and available option. And that is absolutely true because we ourselves are not that much aware about it. A major barrier hindering preferable fertility preservation practice is the lack of a structured, coordinated fertility preservation program, especially in our country. And the education of healthcare professionals is very important. Clinicians' knowledge and attitude towards fertility preservation significantly influences fertility preservation practice. While some physicians have realized the sensitivity and
Sorry to
importance
interrupt you, ma'am. Your time is up, ma'am.
Importance of fertility issues, oncologists tend to provide treatments that maximize the chances of survival and regard fertility issues as non-priority. Accomplishing the objectives should start with educating healthcare professionals, possibly including pediatric oncologists, radiation oncologists, gynecologists, urologists, hematologists, surgeons, and nurses. And informed consent is very, very important. All the sensitive aspects have to be really explained, and referral system should be very, very much precise, and there should be a direct link between the clinical team and the fertility preservation team. So the future directions are that there is massive follicle atresia after transplantation with more than 70% primordial follicles failing to survive, and studies should focus on promoting follicular survival by enhancing revascularization, reducing ischemia, reperfusion injury soon after transplantation, and strategies should include transplanting ovarian tissue with biocompatible decellularized extracellular matrix scaffold and utilization of antioxidants, anti-apoptotic agents, and pre-angiogenic factors. Artificial ovary again is in demand. Maybe sometimes it will happen. And again, testicular tissue autograft needs many clinical trials. So my conclusion is fertility preservation is an increasingly important issue in pediatric and adolescent care health, as most malignant diseases these days are curable. Mature gamete cryopreservation is the most reliable and successful strategy for fertility preservation when embryo freezing is not practical. In addition, ovarian tissue cryopreservation is an effective option for female fertility preservation, though there is room for improvement in its efficacy. Autograft of immature testicular tissue is currently the most promising method for prepubertal males, but still is an experimental stage. There is a need for good government-funded fertility preservation program. So I wish to thank you all for the patient listening.
Thank you, Dr. Asha, Madam. It was really a wonderful lecture, truly updating, very interesting and very informative. Thank you so much. Especially
I would like to thank my dear friend Sampath for inviting me. She insisted that I have to give this talk. I was trying to escape a little bit because today there were 3 webinars and there were so many activities in the hospital because of the World IVF Day. So since morning I've not gone home. I'm just doing this.
Really nice, Asha. Only you can talk this.
Oh, so nice, Sampath. So nice. Thank you.
Asha, one request by the delegates. What is that 17th and 18th question, Supriya? They wanted her to discuss. 1 minute, Asha.
Yes, sure.
See that 17th and 18th question, they have repeatedly asking about that
Supriya, you are muted.
Sorry, ma'am, I have not checked which questions.
I will tell 1 minute. Asha, planned oocyte preservation, cryopreservation requires that discussion, they want that question. And long GnRH agonist prior to chemotherapy. These two questions.
Yeah, I've already discussed about the GnRH analog. You give GnRH analogs, so you suppress all the estradiols and everything, gonadotropins, and it has been suggested because then that those levels are not there, so the toxicity, gonadotoxicity is not much. So you can give chemotherapy, and it has been, many people are doing it. Still, it is controversial. Maybe Sarita may talk about whether she is using GnRH, long GnRH analog or not. And about the planned cryopreservation, this is an easy thing. If a girl has got malignancy and you have got 2 to 3 times, then these days we start random start protocol, and in that we start stimulation because we don't have to transfer, so we are not bothered. So we just stimulate the ovaries, take the oocyte out, cryopreserve them. We use immediately after the retrieval, within 2 hours, we freeze them after removing the cumulus. And then whenever the girl grows up and she wants pregnancy, we can use those eggs and then make the embryos and transfer like any other cryopreservation program. Sarita, do you use GnRH analog? Are you fond of using GnRH analog? Before
right now we are not using, because the the chemotherapy actually cycles are short. It takes about 3 to 4 months for them to finish the chemotherapy, and following that, in about 1 or 2 years they regain their the regular cycles.
So what they are
this,
saying that
in fact,
before you start chemotherapy, you give them long down regulation, because these days these GnRH analogs of the 11.25 or 11.75 milligrams are available. So they are effective for almost 3 to 6 months. So if you give that, then maybe that protects the toxicity. So there are lots of benefits on it. And it is such a simple thing, easily available, and it is not so expensive in our country. So I think it's a very simple way of fertility, preserving the fertility in adolescents, especially when the parents are not ready for oocyte cryopreservation and they don't want to spend this much. They are happily ready to.
Yes, true.
Thank you, Asha and Sarita. Thank you, wonderful speech.
Thank you, ma'am.
Okay, now we will go with the post test. I think all are asking about the post. Thank you, Dr. Asha. I thought we should not miss you. I miss you talking.
So you made it point that I talked, and I think I got a very good slot.
Fantastic.
Just talking after Sarita was the best thing to do.
Yes.
Because you are dwelling in that cancer thing, and then you understand. So it's a very good thing. Yeah.
Neelima, can you
Thank
post?
you. Thank you. Me also now take permission to leave. Thank you so much.
IVF Day. Thank you, Anita. See you soon.
Thank you. Thank you.
Yeah, sure. Bye.
Neelima, can you post the link? Chat.
Yes,
Post test link. Delegates, the link will be in the post test. Please start answering 20 questions, 10 minutes.
All delegates are requested to please fill in the post-test questionnaire. Link is sent in the chat box. Without giving post-test, your certificates will not be issued. So please do the needful. We have the last around 6.15 minutes remaining. Last 1 minute remaining. Those who have not submitted, please do so immediately. ICOG team, Sampath madam has joined from a different device. So please can you unmute her? And also please display the question answers. So I'll read them out. So thank you. Meanwhile, thanks to all the delegates, to all faculty, chairpersons, especially to Sampath ma'am for all the efforts that she has taken. I will quickly go through the questionnaire. I'm giving the correct answers. So which of the question number 1, which is of the following is the most common type of ovarian cancer found in adolescent girls? A, epithelial tumors, B, germ cell tumors, C, stromal tumors, and D, secondary metastatic tumors. Answer is B, germ cell tumors. Second question, what is the common symptom of ovarian cancer in adolescent girls? A, frequent headache, B, bloating, abdominal bloating or swelling, C, persistent cough, D, joint pain. Answer is B, abdominal bloating or swelling. Third question, which diagnostic test is typically used first to evaluate a suspected ovarian tumor in adolescent girls? A, MRI, B, PET scan, C, ultrasound, D, X-ray. Answer is C, ultrasound. Question 4, which tumor marker is often elevated in cases of ovarian germ cell tumors? A, CA125, B, alpha fetoprotein, C, PSA, D, CEA. Answer is B, alpha fetoprotein. 5, following is the changes of adolescent except A, enlarged genitals, B, a second sexual attraction, C, change in attitude, and D, non-risk behavior. Answer is non-risk behavior. Sixth question, consequence of teenage pregnancy except 1, high MMR, 2, macrosomia, 3, anemia, 4, lactation failure. Answer is 2, macrosomia. Question 7, who can provide sex education and counseling? 1, teachers, 2, doctors, 3, peer educators, 4, community workers, and 5, all of the above. Answer is all of the above. Can you move the questions up? Which of the following is not an amendment in MTP Act 2021? A, increase in gestational age for termination of pregnancy. B, inclusion of unmarried women. C, requirement of 3 medical practitioners for MTP after 20-week gestation. D, provision of a medical board for MTP about 24-week gestation. Answer is C, requirement of 3 medical practitioners for MTP after 20-week gestation. 9th question, who amongst the following is part of medical board? A, family planning counselor, B, geneticist, C, radiologist, D, psychologist. Answer is C, radiologist. 10th question, which form mentions the indications of for MTP after 20 weeks? Answer A, form 1, answer 2, form 2, C, form D, D, form E. Answer is D, form E. Which health program in India is intended to reduce teenage maternal death? This is 11th question. A, RMNCH, B, NRHM, C, JSSK, D, ARSH. Answer D, ARSH. 12th question. As per WHO, adolescent aged 15 to 19 years in low and middle income countries had an estimated pregnancy rate of 16 million, B 25 million, C 21 million, and D 30 million. Answer is 21 million. C option. 13th question. What are the complications in the newborn of adolescent mother? A. Low birth weight and preterm. B. Perinatal and neonatal morbidity. C. Congenital malformation. D. All of the above. Answer is D. All of the above. 14th question. As per NFHS 5, women aged 15 to 19 years who are already mothers or pregnant at the time of survey. So what is the A 6.8, B 8.6, C 26.3, D 12.7. Answer is A 6.8. 15th question. Alkylating chemotherapeutic agents A do not affect fertility. B affect gonads of male as well as female. C affect only males. D affect only females. Answer B affect gonads of male as well as females. Question 16. Advantages of orthotopic transplantation of ovarian tissue in remaining ovary or peritoneal pocket in broad ligament. Answer A. Natural conception possible. B. It always requires ART. C. It is experimental. D. It is easier than heterotopic transplantation, and repetitive transplants are possible and cost effective. Answer is A. Natural conception is possible. Question 17. Planned oocyte preservation requires A. At least 4 weeks prior to chemotherapy. B. After thawing, IVF can be done. C. After thawing, always ICSI required. D. Slow cryopreservation in the freezing choice. So C. After thawing, always ICSI is required. Next question, 18. Long GnRH agonist prior to chemotherapy is A. Has no role. B. Only in perimenopausal women with breast cancer. C. Low risk of POI and higher number of spontaneous pregnancies have been reported in some studies. D. There is strong evidence of use in adolescents. Answer is C. Lower risk of POI and higher number of spontaneous pregnancies reported. Question 19. Fertility preservation may be required in A. Klinefelter syndrome, B. Turner syndrome, C. Endometriosis, D. All of the above. Answer is D. All of the above. Question 20. Which of the following is not true about precocious puberty? A. Defined as puberty starting before statistically specified age 2.5 SD below population mean. B. As per latest guidelines for girls, it's considered precocious if breast development or pubic hair appears before age of 7 in white girls and age 6 in black girls. C. In boys, it is defined as testicular enlargement more than 4 ml or pubic hair stage 2 before age of 10 years. And D. 5 to 10 times more common in girls. What is not true is option C. In boys, it is defined as testicular enlargement more than 4 ml or pubic hair stage 2, not before 10 years, but before age of 9 years. So I think that brings us to the end of this questionnaire. And Sampath ma'am, over to you for vote of thanks and instructions for tomorrow.
Thank you, Supriya. So thanks to the Dr. Jaideep Tank, Dr. Madhuri Patel, and Parul sir, Sarita, madam, for giving the opportunity to conduct this workshop. Today is our day 2, and thanks to the speakers, Apurva Kumar Datta, Dr. Radhika Gauri, Dr. Ajal Thakkar, Dr. Supriya Arvari, Dr. Reena Vani, Dr. Asha Bakshi, and Lakshmi Srikande madam, and Dr. Sarita. You had the wonderful talks. I think all of you would have been benefited by these talks. And thanks to all the chairpersons, Dr. Anita, Dr. Alka Pandey, Dr. Meena Samant, Dr. Ranjana Khanna, and thanks to all the delegates who are joined. Tomorrow, again, tomorrow is the last day, day 3. I request all of you to join by 4 o'clock. And the pre-test will be started by 4:15 or 4:30. So if you join early, we can finish it early. Tomorrow also you have the wonderful talks. So I thank everyone, and a special thanks to Supriya Arvari, who has been continuously moderating from yesterday, today, and tomorrow. To Radhika Gauri also. Thank you. Thank you to Neelima. Neelima, thank you so much. So we meet you all on tomorrow 4 o'clock.
Yes, thank you so much, Sampath ma'am and Neelima. Sampath ma'am, I think, is not slept for last 1 month because of this course. And Neelima also has been working tirelessly. So thank you, ma'am,
Thank
and we'll
you.
see you tomorrow.
Meet you tomorrow. Thank
Okay.
you.
Bye-bye.
Bye, Nilima.